so that we can have a survey and then come out with a plan of action and to ensure that everyone who needs treatment for rare diseases, in Puducherry we handle them irrespective of whether it's affordability or not. That, to that extent, I again congratulate the organizers for this event and take this opportunity. Once again, I am thanking you for inviting me. I have an urgent work, they have to go. I take sorry and I want to say thank you again. Thanks a lot.
I request Mr. Varada of Kotak Bank to give a memento to our Health Secretary, Mr. Uday. And I am requesting Mr. Anil Raina to give the son of the book about the lysosomal disorders to the Health Secretary. Requesting Ms. Monica to present a stall to Mr. Uday. Shawl. Mr. Uday. Dr. Monica, you can present a shawl to sir. Sir, Varada sir. This is a way of recognizing our partners in this Health Connect initiative. Thanks a lot for coming, sir. Yeah. Yeah?
State level meeting.
Okay. Thank you, sir. Thank you. And it's extremely happy that Dr. Nalini was honored here, but we'll have a formal Lifetime Achievement Award being given to Dr. Nalini by our governor or CM. Depending upon who is going to come first. And we'll have a formal inaugural after this first panel talk, which it was supposed to be for the CEO's panel talk. And I request our others to come to the dais, and we'll start the CEO talk, and then when the inauguration comes, we'll have the other regular formalities to proceed, sir. Yes. Dr. Nalini ma'am, there is going to be the panel talk has been shifted because of inauguration. We'll have a CEO panel talk now, and then we'll have the other regular ma'am. Request you to come to the. Okay, you can be seated also. No, we are starting the CEO panel talk, and your panel is coming later, ma'am. Yeah. First panel talk. Panel talk. Hand mic. Panel. Saravanan, first panel PPT போடுங்க. As I said in the earlier, we are going to have this whole conference in terms of medical fraternity being part of it. The industry panels, various leaders from industry are going to be part of it, and academic partnership is there. So we are trying to bring in thoughts from various uh, segments of industry to bring in how we can go towards a paradigm shift in managing the healthcare rare diseases, because it's one of the toughest way to act and a lot of complexities are there. So first we are starting with a panel, which is, we have Mr. Anil Raina, Mr. Suresh Venkatramani, and then Dr. Monica, and Mr. Girish, and Mr. Raja. And we will discuss on this topic what it takes corporates to challenge the status quo, and what should be done to bring the paradigm shift in thought process of CSR impact, funding, insurance, and other models of assistance. Can you show the next slide? And then we'll have, I request Mr. Prashant to come to the stage. Okay. And then we'll have Ms. Sabita walking in to join us in the panel. I request the panelists to start few minutes with 2 minutes views on this topic, and then we'll go for panel discussion. I request anyone to start the discussion. Yes.
Good morning. Am I audible? It's a pleasure to be here today, and thank you, Professor Sridhar, for inviting us to the meeting. Before I start with my views, I would like to also share one observation that I came across. I met Professor Nalini for the first time today, and it's a great honor for the entire rare disease community, because two people who have worked tirelessly in this space have been recognized by the Government of India this year with the Padma Shri. One is Dr. Nalini and Professor I.C. Verma in Delhi, one doctor from the northern part of the country, the other one from the southern part of the country. And I think this shows how the government is also recognizing the need for having, a policy in place in working towards the welfare of patients with rare diseases in the country. We saw that as a first step in 2021 when the National Rare Disease Policy was announced, and now with the funding announcement last year when 50 lakh rupees have been allocated by the Ministry of Health. These are first steps towards recognizing that people who have rare diseases need to be taken care of by the government. And it's not just the government. I think we as a society have to all come together and see what we can do to have a sustainable solution for children with rare diseases or people with rare diseases. Now, the first question which was here is how do we challenge the status quo? Now, I belong to a company called Sanofi Specialty Care. Within Sanofi, there's a business called Specialty Care, which traces its origins to a biotech company called Genzyme, which was founded in 1981. And we challenged the status quo in mid-80s when we started working for developing the treatment for Gaucher disease. At that time, in the US, while there was an orphan drug, there was not a commercially viable therapy for rare disease available even in the US. So I'm essentially talking about the developed markets in mid-80s. But we still thought that let's challenge the status quo and see what we can do and how we can bring relief to children with one of the rare diseases called Gaucher disease, which is a lysosomal storage disorder. We launched our first therapy in 1981. At that time, we did not really have a commercially viable model available. But what we did was we worked with insurance companies in the US and going forward, in other countries with the governments to develop sustainable funding solutions for children with rare diseases. So we challenged that status quo that people will probably need to pay for it, because when we talk about rare diseases, the patient populations are small, which means that drugs which are made available, treatments which are made available, the cost of treating the patients is very high. And it is not sustainable for any family to really bear the cost of treatment. So essentially the idea was it is either the insurance or the governments in different countries, as the case may be, they should take care of people who have these rare disorders. And this is what we did over the last many, many years. What we also did, and here again I'm starting from the US only because we also launched a humanitarian program in 1991, because we recognized that not everyone can have access to to therapies with rare diseases. That single therapy that we had. So this humanitarian program was conceived basically so that children who are in any other part of the world, if they need this therapy, they could approach us and they could get access to this therapy. And why am I sharing this with you? Because while we set up our operations in India in 2007, in 1991, there's a family from Mumbai that approached us. And that is how we started our footprints in India. That is how we started our journey in India. And that was the start of our humanitarian program in India. Over the years, as we set up our operations in 2007, to now, we have close to 150 odd children and adults now who are benefiting from our charitable access program. So in India also, when we started in 2007, we were, I would say, the pioneers at that point of time because nobody had really heard of rare diseases. Very few people would really understand what rare diseases are. And it was a big challenge working with physicians, working with government officials. Even there were no advocacy groups, barring in hemophilia and in DMD, there were 2 advocacy groups. Otherwise, there was no other advocacy group as well in rare diseases. The first Rare Disease Day was commemorated in 2010 by the Lysosomal Storage Disorder Support Society. These are baby steps that were taken at that point of time to see how the ecosystem could be developed for rare diseases. We started a diagnostic program in 2013 so that diagnosis access could be made available to patients with rare diseases. So this is all about really challenging the status quo, that while this is not existing in the country, let us do something to develop a rare disease ecosystem so that finally something can be made available to people in the country. And that is, eventually that led to the formation of the policy in 2021. And I've taken, I think, more than the required time, so I'll end my talk here.
I request Monica to share the initial points.
Good morning, everyone. I'm Dr. Monica. I represent Roche here as the Chief Country Access and Policy Officer. This topic is very close to my heart. I mean, challenging the status quo. The very fact that we are sitting here and talking about rare diseases in itself challenging the status quo. Why I say this? Because, we've all been through this pandemic since 2020. And what has changed in this world post the pandemic is the importance of healthcare and access to quality healthcare services. Thinking about health system strengthening, thinking about universal health coverage. That was not challenging the status quo because this was an expectation right from the time when Millennium Development Goals came in and Sustainable Development Goals came in. But how we are challenging it now, that we are thinking that we do not want to have another pandemic. And here I'm not talking about another infectious disease. I'm talking about a pandemic of rising burden of non-communicable diseases. And when I'm talking about non-communicable diseases, I'm not forgetting that as a sustainable development goal, there is an expectation leaving no one behind. And when we say leaving no one behind, we also mean that leaving not the rare disease patients behind. And why is it rare disease? It's not rare because it's something that we can ignore. It's rare because it's fragmented and it's scary for anyone who has a rare disease patient in their family to really take care of that patient right from the childhood because he probably inherited it in his genes to the time he's, alive in this world. And we will not be able to achieve sustainable development goal. We will not be able to have universal health coverage until the time we really start to emphasize on these rare diseases. And for our country like India, rare diseases are no more rare because we are talking about it, because we have now, centers of excellence coming up. And the role that corporates can play, that is why we are here to discuss how we can help the multiple stakeholders in the healthcare system to come together and discuss about what sort of services that need to be there in terms of tackling with these rare diseases, what sort of financial assistance that should be provided in tackling rare diseases, and how do we make it their life better than what they have inherited from childhood. And just one more line, because I know we'll go into the panel. And talking about Roche, all I want to bring it to the table is we come here with a mission, and the mission is doing now what patients need next, which means we are already looking into the pipeline of all sorts of rare diseases. And Roche has always been known as the dominant oncology pharmaceutical company. But what we are focusing now on rare diseases, on neurosciences, looking at mental health issues, looking at Alzheimer as well. And that, to me, is the real challenge that we are putting to the status quo. Thank you.
Thanks a lot. We heard from pharma company CEOs. Now I request Mr. Girish, who comes in a different note. He is a unicorn of a startup called Maxter, and who has digitalized the print media. And I would request his thoughts on how we should go or handle the status quo.
Thank you, Dr. Sridhar. I'm a bit of a misfit in this panel, in the sense when Dr. Sridhar told me about this event, I'm like, I have no connection with, other than trying to be healthy, but otherwise no connection. And then he said, no, the angle that we are looking at is not just corporates and CXO kind of discussion, how to think out of the box, right? Because I think that's very important. And after listening to a little bit of what's going on, I think one is rare diseases, and one is, I think, general healthcare itself. A lot of awareness is to be created first, right? And I mean, one thing comes to mind in this age of, social media, and, people are blissfully unaware of what is the real goings on. But taking a simple example of maybe the ALS that happened some few years ago. I mean, I'm saying happened because there was something called the ice bucket challenge, right? So nobody heard of ALS before that. Now everyone knows ALS because somebody in the family or somebody in somebody's family challenged somebody on social media. So they used social media to create awareness. And I think not only did they now get multi-million-dollar aid and focus onto something rare like ALS. So similarly, I think other rare diseases need not only, champions for the cause, but also I think we can use technology in a very useful way. Especially, at Maxter, what we did was basically take print media and move it digital. So we changed the status quo. Everyone was reading print. The whole world was going towards mobile device. So we chose that particular niche. And now we are kind of the Netflix of reading. So, and going back to our connection with healthcare, we really didn't have much of connect with healthcare other than the content that is available on our platform. And then we went back to doctors and went back to hospitals. And now we've got this thing called smart reading zones. So at Maxter, you can actually create any location. Like this conference room can become a smart zone where everyone here can read the latest in their field or subject for free, which could be either sponsored by the zone or by an external sponsor. So you can always keep innovating. So I think the question is, to get the corporates involved, I think one is on the innovation side, one is on the technology side, and one I feel is to create a database of patients who have some connect with corporate. Like for example, if there's someone with a rare disease in our company, we will get to know about it. And from our end, we may end up helping that patient specifically, or someone in the family who has some rare disease. Then people who have high net worth individuals, for example, if there's a database and say that, okay, these are the 100 people who have, millions of dollars or billions of dollars in hand, or having the right connects, or there's somebody in the government service, somebody in an IAS officer's family who has a rare disease, you will immediately start getting more funding or more attention to that. I think that is something that you can use technology and awareness to bridge that gap, while I think the heavy lifting of creating, the actual medicines and, caregiving is done by the rest of the...
for the last 2 weeks, I've been interacting with him, and how he has kind of put together a forum where, he's got people from government, he's got people from the pharma industry, from financial services industry, and HR veterans. I think this is no better platform for us to kind of brainstorm on this. A quick few thoughts on what we are up to. I mean, my name is Venkatramani Suresh, and I represent a company called Karkinos Healthcare Private Limited. We are probably the first health tech startup in India to focus on the early detection of cancer, funded by the Tatas, Reliance and Mayo Clinic. And in my own humble journey over the last 2 years, what we have witnessed is, as Professor was talking about, the paradigm shift. Though I don't have a pharma background, I'm not a doctor, I have actually spent 20 years building a company called Naukri.com, and what we are trying to do is to kind of replicate what we did there. I mean, we kind of, for want of other words, I would say we are looking at Uberization of cancer. What I mean by that is completely a different view, a paradigm shift from thinking from illness to wellness. And when you start approaching a problem and reverse the pyramid, I mean, today, as per a WHO report, in India, 1 in 8 Indians are likely to have sign or symptom of cancer. And 70% of all these cancers are detected at a stage 3 or stage 4. And stage 3, stage 4 cancer, the probability of survival is less than 90%, less than 10%. And the cost of treatment is exorbitantly in the range of 14 to 20 lakhs. And honestly, no middle class human being can afford a stage 3, stage 4 cancer today if he is not covered by an insurance. And 90% of the population in India are not covered by it. So what we are trying to do, the paradigm shift that we are looking at is, can we reverse the pyramid? Instead of 70% of the people getting detected at stage 3 or stage 4, can we do a very organized or an institutional approach to early detection of cancer? In this, we partner. The reason why we kind of chose HR community as our first target audience is, today, if I look at the organized and unorganized, or the blue collar and white collar workers put together, who today have access to high quality internet connection, and we being a digital platform, we have put together a simple digital risk assessment which somebody can take in less than 10 minutes, which will give them a fair idea of probability of cancer. And we work with a whole bunch of hospitals, clinics, stalwarts like Roche in our journey. So, just to summarize, our intent is to kind of work on early detection of cancer, and that probably to me is a 360-degree paradigm shift. Thank you.
One small announcement. We'll have Honorable Governor coming in 10-15 minutes. I request Sabita to give one quick thought, and then Sabita is the HR head and she's a good friend of us, and she has a lot of work on CSR. One few minutes, Sabita.
Thank you so much, Shri, and I call Sridhar Shri, so all right. First of all, very good morning, everyone here, and I would like to actually start with a standing ovation to this wonderful community we have surrounded here with, the doctors, people from the pharmaceutical. So my salute to all of you, because you saved lives. Thank you so very much, and thanks so much for joining me. Please have your seat. I start with that because, many of us probably got so vexed with the vaccination drives, and that included me as well, because initially we were so paranoid, right? Anything new, Indians get paranoid. So we do so much of Google searches. Do we really need to go for a vaccination? So my journey started there in my organization, right? And this was a very, very difficult time for everybody, because I personally happened to lose about 9 or 10 of my colleagues to COVID during the second wave. So that was sad, and I'm in commune with their families even today. So that's why I said hats off to all of you, because, though they did mint a lot of money, the vaccine companies, but, they sure saved lives. Coming back to, actually, Suresh, you stole my thunder when you said illness to wellness, because that was something, I wanted to speak about as well. We have, the last couple of years, at least 2.5 years, we have focused more so on, the preventive and, realize what employees in the corporate sector will be going through. So we created these, happiness champions amongst the employees. And that was a shift, because whosoever would have thought of mental wellness, because it's such a taboo topic in our country, right? The moment you say, I'm mentally stressed, the only word which stays with you is the word mental, right? So we have had to create a lot of buzz about mental wellness by bringing in customized employee assistance programs, or EAP as they're commonly known. And that helped because right from anger management to parent management to spouse management, any and every topic under this broad spectra or gamut of stress was included. Different people, different strokes. So this actually took, it was received very well because people were so shy to talk about this. We had an entire fleet of medical counselors, right? Not just the doctors who were in the forefront, but medical counselors, medical advisors who came forward. Virtual, yes, but many of them have helped save lives, not just from COVID, but also from this so-called mental paranoia. That was one big thing that we had done. The second was, trying to create rare disease. My first, I would say, introduction to this word called rare disease was when I lost somebody to the autoimmune disorder, someone very closely known to me. And I was shocked because he was a perfectly healthy looking person. One would not have thought that he could have had this. So we got into it as an organization. We said, let's work on this because you see, not everybody has the financial resources to handle it.
I'm getting hints from
Closing
Governor's office.
Yeah, sure, thanks.
We'll subsequently
So, that's something which took on importance. And I think all of us need to understand when people behave in a certain manner, we can't write them off. We need to see how we can support, and that's something that we really worked on. So in the interest of time, I'll give it back to you, Shri. Thank you.
And apologies for this. Since Governor is coming in, we have to reorganize the stage as per the protocol. It's a quick thing, but we'll come back again to this thing. And thanks a lot for all of you. And we'll give the mementos and other recognition later. Apologies for this. Thank you. Thank you. Since we have to maintain protocol guidelines, we have to rearrange the stage completely now. I welcome every one of you and request you to give a big applause for Honorable Governor who has come in midst of a busy schedule. I welcome one and all. Before that, we'll raise for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय 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 हे.
We'll raise for Tamil Taiwan.
வாழ்வினில் செம்மொழி சீரமும் வெற்றியும் நீயே தாங்கிடு இலையில் உனை விருத்தேனோ தமிழன் நாடும் தலை குனிவேனோ சூழ்ந்தின்பம் நல்கிடும் வைத்தமிழன்னாய் தோன்றுடல் நீ உயிர் நான் மறப்பேனோ செந்தமிழே உயிரே நருந்தே செயலினை மூச்சினை உனக்களித்தேனே நைந்தாயனில் நைந்து போகுமென் வாழ்வு நன்றினை உனக்கெனில் எனக்கும் பாரே முந்திய நாளினில் அறிவுமில்லாது மொய்த்தனன் மனிதராம் புதுப்புனல் மீது செந்தாமரை காடு பூத்தது போல செழித்த என் தமிழே ஒளியே வாழி செழித்த என் தமிழே ஒளியே வாழி செழித்த என் தமிழே ஒளியே வாழி.
Thank you. Any event starts with lighting of the lamp as per our Indian tradition. I request Governor Madam to inaugurate the Health Connect with lighting the lamp. And to give a brief, Health Connect is with the guidance and blessings of Honorable Governor, Honorable CM, and direction of Health Secretary, as we said earlier. And we have the person who is working behind the scenes, Dr. Sriram here, guiding us for last 1 year. And Just a brief about this Health Connect. Our aim is to bring in a paradigm shift on the way in which we look at managing the rare diseases. And this is the first unique initiative we have started in Puducherry government and will be taking across India. And we want to bring in corporate authorities, industries, industrialists, then academic research, and people across the health sector as a one industry, as a full group of industry to look into the tough management of rare diseases. And this conference is, as we started in the initial panel discussion, we'll be going across through the day as a continuing medical education program for all the doctors who have come from Puducherry who are gathered here. This is a brief note about us. And we'll go in, start with felicitating Dr. Nalini Madam with a Lifetime Achievement Award. I request Honorable Governor to give this Lifetime Achievement Award. According to us, she's a living agent for the hemophilic patients in Puducherry. And as I said, we have brought in various partners in this initiative to be a continuous engagement activity. We have representation from Sanofi Pharmaceuticals, Mr. Anil Raina, who will give what is the planning document for the going forward after this Health Connect initiative. He will give an actionable document to our Director, Medical Services, Dr. Sriramlu. Mr. Anil Raina. This is an actionable document which will pursue after this conference, ma'am. I request Mr. Suresh Venkatamani to give the activity document proposed to Puducherry government. Preeti. Go down. Dude. I request Dr. Monica to present the document on the rare diseases to Director of Medical Services. I request Mr. Suresh Venkatamani to honor Director of Medical Services. Now we have come to the important moment of the inaugural. I request our Honorable Governor Dr. Tamisai Madam to inaugurate with the keynote address.
A special good morning, that is good afternoon to each and everyone here. First of all, I am very happy to inaugurate the Health Connect conference. Founder of Order of Genetic Support Services, Srimati Preeti Rajagopal, Srimati Batmashri Madam Nalini, founder HFI Puducherry chapter. First of all, we are very happy that after her announcement as Batmashri, we are all congratulating her. And this is the beauty of our central government, that hearing the, as it is said in the Sanofi genozyme, this, when our, you are from Sanofi. Sanofi, when he presented me the book, Roar for Rare. You have to roar for the rare people. Like that, hearing the unheard voice, identifying the silent workers. Our Honorable Prime Minister always says, Batmashri awardees should be the real people service-oriented persons who are silently working for the welfare of the people. So, Madam Batmashri Nalini is of such a kind of person, for a long time, very silently working on hemophilic patients, and I'm really happy that she is sharing the dais with us. Particularly in this conference, because we are focusing on such things, so I'm very happy that she is in this conference. And Thiru Anil Ratna, General Manager Sanofi, Thiru Suresh Venkatramani, co-founder, Caricnos Healthcare, and Sri Ramulu, Director Health, and Sridhar Narayanan, Advisor, Order, the Genie Support Services. Anyone I have left? Dr. Monica of Roche. Dr. Monica, and all the dignitaries who are attending this program, specialists, academicians, health workers, medical fraternity, press friends, my security personnel, and my wishes to each and everyone here. First of all, I am Philia. Health is a key component of the Sustainable Development Goals in the modern period. Before inaugurating this program, when the organizers came and asked me to inaugurate this program, actually, in fact, I am a fetal therapist. I was working exactly on this. Chromosomal abnormalities. I was doing chordosynthesis, amniocentesis, chromosomal studies, genetic studies. When I had this idea of going for fetal therapy, in fact, I am the second person who went for fetal therapy studies from Tamil Nadu. And I went to Canada for getting my specialization as the fetal therapist. Why I went? Because you all know I studied gynecology. Common saying says, mother delivers, gynecologist gets the fees. So all gynecologists are really very comfortable and relative to me. But my focus was when I happened to see as a sonologist. Before fetal therapist, I was working as a sonologist before my gynecology studies. I used to have sleepless nights when we diagnose children with anomalies. particularly children with anomalies, the later trimester. You know, if the earlier trimester, if we diagnose, immediately it can be terminated within the limits of the law, or some advice or some correction could have been done. But when we diagnose it at the later stage, third trimester, it's disheartening. I can say one story. One lady, I diagnosis almost 9th month, big hydrocephalus, very big hydrocephalus. And I was asking her, 9th month you have come for an ultrasound. If you could have, because the size of the head indicated me, definitely it could have been diagnosed at the earlier stage. So I asked her, why didn't you come for the scan at the earlier stage? We are asking the patients to come for a 12-week scan, 16-week scan, and follow-up scan, 30-week scan. Why didn't you do? She was telling, she was from a remote place, and she was telling me, when we wanted a scan, my mother-in-law told, scan and all very harmful. We didn't have any scan. We had very healthy babies. Nowadays, you people only wanted to have everything. So no need. Your husband was a healthy baby. I didn't have any scans. So they didn't have any regular checkups. And the poor lady underwent cesarean for a baby which was not alive, which could not be saved. And I, as a fetal therapist, if we could have diagnosed at the earliest stage, even shunt procedure could have been done, or any other procedures could have been done, or probably could have mentally prepared the patient, or could have been terminated at the earlier stage. So much of studies could have been done. So I am really happy when somebody is initiating this Health Connect, so that concentrating on the anomalies, the chromosomal abnormalities, and nowadays the people are much aware about it. But in spite of that, there is significant percentage of the people who are all not aware of such things. So I'm really happy these conferences definitely will create awareness among the public. Because creating awareness among the public is very important than these facilities, sophistications we have. For example, when I was practicing 35 years before 35 years, that was one of the pioneers in ultrasound, because only one machine we had at Tanjavur Medical College, in the medical college, and I was having another machine outside. And when I called a person to study his prostate, I told, next day you have to come with full urine, so that comfortably the prostate could be studied. The next day the patient came, opened a yellow bag, he put one Horlicks bottle full of urine, second Horlicks bottle full of urine on my table. What is this? I was asking. He told, no, you only asked me to come with full urine. So, creating awareness among the public and making the public to understand, it is the most important thing which we have to do. So when these conferences, I always feel whatever may be the development, we may be having the gadgets, the world-class gadgets, but it should be useful to the poorest and poor. Unless it is useful to the poorest and poor, no use in creating such an infrastructure and reaching out such world-class facilities. It should be helpful to the poorest and poor of the person. So how it could be achieved? So conferences and getting connected like this, definitely it will help. And particularly identifying the correct problem. For example, these anomalies we know, neurological anomalies. So the nutritional state of the mother should be corrected in the preconceptional stage. Preconception pre-conceptional stage itself, nutrition should be supported. But most of our government schemes are giving nutritional kits during the pregnancy. So I had an MOU with the National Institute of Nutrition at Hyderabad, and we worked on it. And they felt that the awareness among the gynecologists should be there. It's not among the public. First, the gynecologists all should be aware that they should alert the patient, advise the patient to get nutritional food in the preconceptional stage. Most of the gynecologists are not advising that. So first, before alerting and making aware the public, the gynecologist should be made aware of the preconceptional nutritional state of the mother. So we all think that people cannot, but the practitioners also should be aware of the problems, particularly when conditions like chromosomal abnormalities, anomalies. I have seen nuchal thickness at the very early stage, and I have diagnosed Down syndrome very early. In fact, I have presented papers on that also. But when an ordinary not ordinary sonologist, a beginner in the sonology, she may not be able to think that nuchal thickness should be seen and whether umbilical cord structure should be studied. So this type of awareness should be created among the doctors, the practitioners, the young medical students, and then the awareness should be created among the public. So I'm really very happy such conference, because we know that we attend cardiology conference, nephrology conferences, so many conferences. But the initial concentration should be on the pre-birth conditions and the congenital anomalies. And as a doctor practicing sonology, particularly a fetal therapist, I feel definitely they have done a great job. So I congratulate the organizers for this rare disease. And particularly they are concentrating on all the other diseases like rare cancers and hemophilia, spinal muscular dystrophy, lysosomal storage disorders. Really the patient, the mothers and fathers should have much patience in dealing with that patients. I have seen the Institute of Assisted Health for the anomalous children and how the parents toil to make the children to carry out the normal activities. And I really happy to know about Sanofi have come out with a book. And when I was, meantime I was reading some of the stories, very emotional stories. So I request each and everyone, when we read stories like that, we can find out the people among us. Most of them are not diagnosed, particularly in the rural areas. They think a child with normal head, limbs, legs and hands, breathing normally, shouting normally is a normal child. But we see living children among us also. So when we have awareness about these children, among us, when we see children, we can pick them up, and we can send them for special studies or for greater assistance. இங்க நான் சொல்வது என்னவென்றால், இங்க தமிழ் தெரியாதவங்க எத்தனை பேர் இருக்கீங்க? எல்லாருமே தமிழ் தெரிஞ்சவங்க தானே. உண்மையிலேயே இதற்கான விழிப்புணர்வு ஏற்படுத்தப்பட வேண்டும். நான் இந்த கூட்டத்தில் கலந்து கொள்வதில், இந்த மாநாட்டில் கலந்து கொள்வதில் பெருமகிழ்ச்சி அடைகிறேன். ஏனென்றால் நான் இதைத்தான் நான் பயிற்சி பெற்று எனது பணியாக செய்து கொண்டிருந்தேன். குழந்தைகளை, மரபணுக்களின் பிரச்சனைகளை குழந்தைகள் வயிற்றிலேயே இருக்கும் பொழுதே அதை சரி செய்வதற்கான மிக நுண்ணிய படிப்பை நான் கனடா நாட்டிற்கு சென்று படித்து வந்தேன். ஏன் கனடா நாட்டிற்கு சென்று படித்து வந்தேன் என்றால், நான் ஸ்கேன் டாக்டராக பணிபுரியும் பொழுது நான் ஒரு மகப்பேறு மருத்துவராகவே பணிபுரிந்திருக்கலாம். ஏனென்றால் மகப்பேறு மருத்துவர் என்றால் உங்களுக்கு எல்லாம் தெரியும், அவர்களுக்கு சேவையோடு சேர்ந்து அவர்களின் தேவையும் பூர்த்தி ஆகிவிடும், ஒரு பிரச்சனை கிடையாது. ஆனால் அதையும் தாண்டி ஏன் நான் இதை எடுக்க வேண்டும் என்று நினைத்தேன் என்றால், தூக்கமில்லா இரவுகளை நான் சந்தித்திருக்கிறேன். சில நேரங்களில் குறைபாடுகளோடு குழந்தைகள் பிறக்கும் பொழுது இவர்களை எல்லாம் மிக நுண்ணிய அழகாக கண்டுபிடித்து அவர்களை அழகாக்கி இருக்கலாமே, இல்லை என்றால் சீக்கிரமே அதை கண்டுபிடித்திருந்தால் இவர்கள் வாழவே முடியாது என்ற ஒரு நிலை வரும்பொழுது அவர்களை முதலிலேயே அதை முற்றிலுமாக பிறக்க விடாமல் செய்திருக்கலாமே, இல்லை என்றால் பிறப்பதற்கு முன்னாலேயே அதை சரி செய்வதற்கான வாய்ப்பு. இப்படி பல நாட்கள் நான் நினைத்ததுண்டு. ஏனென்றால் குழந்தை பிறப்பு என்பது ஒவ்வொரு குடும்பமும் கொண்டாடக்கூடியது. அப்படி கொண்டாடக்கூடிய குடும்பத்தில் ஒரு குழந்தை பிறந்து அது குறைபாடோடு அந்த குழந்தை பிறந்திருக்கிறது என்றால் அவர்கள் படும் துன்பம் அளப்பரிய துன்பம். அது அன்றைய தினத்தோடு போய்விடுவது கிடையாது. ஆக அதற்காகத்தான் நான் அந்த படிப்பையே கன்னடா நாட்டிற்கு சென்று படித்து வந்தேன். அதனால்தான் நான் அடிக்கடி சொல்வதுண்டு, பல பேர் அரசியல்வாதியாக இருப்பதனால் இவ்வளவு ஒரு துறையில் இவ்வளவு விற்பனராக இருந்தால் என்பதை ஒப்புக்கொள்வதில்லை. ஏனென்றால் சில பேரிடம் நாம் நேரடியாக இவ்வளவு இலகுவாக பழகும் பொழுது அவர்கள் நம்மை மிக இலகுவாக எளிமையாக எடுத்து விடுகிறார்கள். ஆனால் என்னை பொறுத்த மட்டில் நான் பல நேரங்களில் நீட் வரும்பொழுது அதற்கு ஆதரவாக சில கருத்துக்களை சொன்னேன். ஏனென்றால் நான் குறிப்பாக பார்த்திருக்கிறேன், நாம் மிக சிறப்பாக பணியாற்றி அதில் ரிசர்ச் ஆக்டிவிட்டீஸ் என்று முழுவதுமாக ஆராய்ச்சியில் ஈடுபட்டு நம்மோட இத்தகைய குழந்தைகள் இருக்கலாம். ஆக குறைபாடு என்றால் உடனே ஏதோ வெளிப்படை குறைபாடோடு இருக்கும் குழந்தைகள் தான் குறைபாடு இல்லை. இந்த புத்தகத்தை பார்த்தால் தெரியும், அவர்கள் சாதாரணமாக இருப்பார்கள். ஆனால் அந்த நுண்ணிய அறிவோடு அந்த விழிப்புணர்வோடு அந்த குழந்தைகளை பார்க்கும் பொழுதுதான் அந்த குழந்தைகள் குறைபாடுள்ள குழந்தைகளாக இருக்கிறார்கள் என்று நமக்கு தெரியும். ஆக அந்த குழந்தைகளை எடுத்து நாம் அவர்களுக்கான சிறப்பு மருத்துவமனைக்கோ சிறப்பு பயிற்சிக்கோ அனுப்பும் பொழுது அவர்கள் சாதாரண நிலைக்கு வருவதற்கான மிக அதிக வாய்ப்பு இருக்கிறது. ஆனால் நாம் அதனால் தான் இன்னும் நிறைய விற்பனர்கள் வர வேண்டும். மகப்பேறு மருத்துவராக சிறப்பாக பணியாற்றி இருந்தால் நான் இதைவிட மிக செல்வ செழிப்போடு நான் அந்த துறையிலேயே நான் பெரிய மருத்துவராகி இருக்கலாம். ஆனா நான் எடுத்த துறை இதை போல குறைபாடுகளை சரி செய்ய வேண்டும் என்று எடுத்த துறை. இதை போலத்தான் சில மருத்துவர்கள் ஆராய்ச்சி நோக்கு கொண்டு சில பேருக்கு சிகிச்சை அளிக்க வேண்டும், ஆனால் அந்த சில பேருக்கு அளிக்கும் சிகிச்சை மனநிறைவோடு இருக்க வேண்டும் என்று பல நேரங்களில் பணிபுரிகிறார்கள். மேடம் நளினி போன்றவர்கள் ஹீமோஃபிலியா அதில் அவர்கள் பணியாற்றி கொண்டிருப்பதை போல இன்று அவர்கள் அடையாளம் காணப்பட்டு இருக்கிறார்கள். அதற்கு நான் பாரத பிரதமருக்கும் நம் மத்திய அரசிற்கும் நான் நன்றியை தெரிவித்துக் கொள்கிறேன். ஏனென்றால் இப்படி அமைதியாக பணியாற்றி கொண்டிருப்பவர்களை தேடி 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 அவர்களுக்கு அங்கீகாரம் கொடுப்பதுதான் நமது பாரத பிரதமரின் நோக்கம். அதனால் அவர்கள் எல்லாம் சிறப்பாக செயலாற்றி கொண்ட பிரபலமான இருப்பவர்களை மிகவும் பிரபலப்படுத்துவது பத்மஸ்ரீ கிடையாது. பிரபலம் என்று நாம் எடுத்துக்கொள்ளாமல் அமைதியாக நாம் பணியாற்றி கொண்டிருக்க வேண்டும் என்பதுதான். அதனாலதான் இந்த மாநாட்டில் நான் இன்னைக்கு உண்மையிலேயே சிரமமான காரியம், அதிகமாக பயணம் செய்து இங்கே வந்திருக்கிறேன். ஆனால் இந்த விழிப்புணர்வை ஏற்படுத்த வேண்டும் என்பதற்காக, ஏனென்றால் விழிப்புணர்வு ஏற்படுத்தப்படவில்லை என்றால் எவ்வளவுதான் வசதிகள் இருந்தாலும் எவ்வளவுதான் உயர்ந்த தொழில்நுட்பம் இருந்தாலும் அது கடைக்கோடி மனிதனுக்கு பலன் தரவில்லை என்றால் அந்த மிக பிரம்மாண்டமான அந்த கண்டுபிடிப்புகளுக்கு எந்தவித பலனும் இல்லை என்பது எனது கருத்து. எனது வாழ்நாளில் நான் அப்படித்தான் நினைத்திருக்கிறேன். ஹைதராபாத்ல இதற்காக நேஷனல் இன்ஸ்டிடியூட் ஆஃப் நியூட்ரிஷன், தேசிய உணவு பாதுகாப்பு கழகம் இருக்கிறது. அதோடு ஒரு ஒப்பந்தம் செய்து பழங்குடி மக்களின் இதை போல குறைபாடுகள் இருக்கக்கூடாது, பெண்களின் இதை போல குறைபாடுகள் இருக்கக்கூடாது என்று ஒரு மாபெரும் திட்டத்தை நான் நிறைவேற்றி கொண்டிருக்கிறேன். அதே போல புதுச்சேரியிலும் அதை எடுக்க வேண்டும் என்று நான் ஸ்ரீராமுலு அவர்களிடம் நான் கேட்டுக்கொள்கிறேன். இவையெல்லாம் நல்லது நடந்து கொண்டிருக்கும் பொழுதுதான் நல்ல மருத்துவர்கள் வர வேண்டும். ஏனென்றால் நாங்கள் எல்லாம் மருத்துவம் படித்து அதன் மூலம் அனுபவம் பெற்று சிறந்த மருத்துவர்கள் இந்த உலகிற்கு வர வேண்டும் என்று பொதுத்துறையில் சொல்லும் பொழுது, ஆனால் அதை பற்றி கொஞ்சம் கூட தெரியாமல் மருத்துவத்தை பற்றி அடிப்படை உணர்வே இல்லாதவர்கள் கூட எங்களை விமர்சனம் செய்வதுதான் ஆச்சரியமான ஒன்றாக இருந்து கொண்டிருக்கிறது. இப்ப நான் ஒரு அழுத்தமாக இந்த துறை வேண்டும் என்று சொன்னால், குறிப்பாக நீட்டை பற்றி சொல்லும்போது இல்லை இதுல நிறைய பேர் வரணும், கிராமப்புற மாணவர்கள் வரணும், அடித்தட்டு மக்கள் வரணும், அவங்க எல்லாம் வர்றதுக்கு இதுனா நீ 800 மார்க் தானே வாங்கின, உன்னை யார் பாஸ் பண்ணா, நீ இவர் போட்ட பிச்சை தானே நீ டாக்டருக்கு படிச்ச, இப்படியெல்லாம் இணையதளத்தில் எழுதுகிறார்கள். அதனால்தான் சமீபத்தில் கூட ஒரு கூட்டத்தில் என்னிடம் கேட்டார்கள், உங்களை அரசியல்வாதியாக எல்லாருக்கும் தெரியும், நீங்கள் ஒரு அரசியல்வாதியாக ஆளுநரான முகம் எல்லோருக்கும் தெரியும், அக்கா என்ற முகம் எல்லோருக்கும் தெரியும், மற்றவர்களுக்கு தெரியாத முகம் ஒன்று இருக்கிறதா என்று கேட்டார்கள். நான் சொன்னேன், மருத்துவர் என்ற முகம் தெரியாமல் பல பேர் இருக்கிறார்கள், அதனால் தான் பரிகசிக்கிறார்கள், கிண்டல் செய்கிறார்கள். இந்த கைகள் எத்தனை பேரை காப்பாற்றி இருக்கிறது என்று அவர்களுக்கு தெரியாது. பல சமுதாயத்தில் பல பேரை காப்பாற்ற வேண்டும் என்பதற்காகத்தான் பொது வாழ்க்கையில் இருக்கிறோம் என்பதும் அவர்களுக்கு தெரியாது. நான் அடிக்கடி ஒரு சம்பவம் சொல்லணும். ஒருத்தர் ஒரு எம்எல்ஏட்ட கேட்டாராம், எம்எல்ஏ ஒரு அரசியல்வாதிட்ட கேட்டாராம், ஐயா எனக்கு ஒரு வேலை வாங்கி கொடுங்க அப்படின்னு. அந்த அரசியல்வாதி சொன்னாராம், எனக்கே வேலை கிடைக்காம தானே நான் அரசியல்வாதி ஆனேன் அப்படின்னு சொன்னார். நாங்கெல்லாம் அப்படி கிடையாது. ஒரு கிரிக்கெட் வீரர் உச்சத்துல இருக்கும்போது அதை விட்டு வெளியே வர்ற மாதிரி ஒரு 2 மணி வரைக்கும் பிராக்டிஸ் செஞ்சுட்டு ஒரு 10 ஹாஸ்பிட்டல்ஸை பார்த்துட்டு ஒரு மிக பிரபலமான மருத்துவமனையில உதவி பேராசிரியராக இருந்துட்டு பொது சேவை செய்ய வேண்டும் என்ற காரணத்திற்காக வெளியே வந்தவர்களை இந்த துறையை பற்றி எதுவுமே தெரியாது, இந்த துறை பற்றி எந்த அறிவாற்றலுமே இல்லாதவர்கள் நீ பெரியவளா உனக்கு என்ன தெரியும்னு கேட்டுக்கொண்டிருப்பதுதான் கருத்து சுதந்திரம். அதையும் நாம் வரவேற்போம் என்பதுதான் எனது கருத்து. அதனால் என்னை பொறுத்த மட்டில் துணைநிலை ஆளுநராக இருந்தாலும் சரி, ஆளுநராக இருந்தாலும் சரி, இதை போல நிகழ்வுகள் வந்தால் எவ்வளவு சிரமம் இருந்தாலும் அதில் கலந்து கொள்ள வேண்டும் என்று நினைப்பது விழிப்புணர்வு ஏற்படுத்த வேண்டும். இந்த விழிப்புணர்வு பல குழந்தைகளின் பிரச்சனைகளை சீர்த்தி, நம்ம சாதாரணமா இருக்கும் போதே நம்மளுக்கு எவ்வளவு பிரச்சனை இருக்கு, கையும் காலும் நல்லா மூளையும் நல்லா வேலை செஞ்சுட்டு இருக்கும் போதே நம்மளால சில பிரச்சனைகளை எதிர்கொள்ள முடியவில்லை. இத்தகைய குழந்தைகள் எப்படி எதிர்கொள்வார்கள்? ஆக அவர்களுக்கு ஒரு சிறு உதவி செய்தாலும் அது கோடி உதவிக்கு சமம். அதனால் இந்த நிகழ்வு வருங்காலத்தில் குறைபாடுள்ள குழந்தைகள் பிறக்காமலும், குறைபாடுள்ள குழந்தைகள் பிறந்தாலும் அவர்கள் குறையில்லாமல் வாழ்வதற்கும், குறையொன்றும் இல்லை என்று எல்லோரும் சொல்லும் அளவிற்கு இந்த மனிதகுலம் தலைப்பதற்கு இந்த மாநாடு உதவி செய்யும். அதற்காக நான் எனது வாழ்த்துக்களை தெரிவித்துக் கொள்கிறேன். அதே போல கேன்சர் இப்போ ரொம்ப மோசமான ஒரு நோயாக வந்து கொண்டிருக்கிறது. மாற்றுவதற்கு உங்களோடு சேர்ந்து பணியாற்றுகிறோம் என்று அவர் சொல்லி இருக்கிறார்கள். உங்க பேரு சுரேஷ், அவர்களுக்கும் நான் எனது பாராட்டை தெரிவித்துக் கொள்கிறேன். புதுச்சேரி பல விதங்களில் ஒரு முன்னுதாரண துணைநிலை மாநிலமாக இருக்க போகிறது. ஏனென்றால் சமீபத்தில் டிபி முக்து பாரத் என்று நமது பாரத பிரதமர் சொன்னார்கள். அதே போல டிபி இல்லாத மாநிலமாக, துணைநிலை மாநிலமாக இதை மாற்றுவதற்கு சிஎஸ்ஆர் ஃபண்ட்ல 75 லட்சம் ரூபாய் செலவில் ஒரு எக்ஸ்ரே கருவி வாங்கி, ஸ்ரீராமுலு போன்றவர்களின், உதயகுமார் போன்றவர்களின் முயற்சி எல்லாம் இருக்கிறது. அதை வீடு வீடாக சென்று எல்லோருக்கும் எக்ஸ்ரே, ஒரு சின்ன கேமரா மாதிரி தான் இருக்கு, 75 லட்சம் எக்ஸ்ரே போக வேண்டியதே இல்லை, சும்மா கேமரா மாதிரி எடுத்துட்டு அவங்களோட செஸ்ட்ல டிபி அட்டாக் இருக்கான்னு தெரியும். இந்தியாவிலேயே முதல் முறையாக புதுச்சேரியில் இந்த பரிசோதனை நடைபெற்றுக் கொண்டிருக்கிறது. இதற்கு உங்களது ஆதரவு வேண்டும். அதே மாதிரி கேன்சர். ஆக எல்லா விதத்திலும் புதுவை ஒரு முன்னுதாரண மாநிலமாக திகழ்வதற்கான அத்தனை முயற்சிகளும் மேற்கொள்ளப்பட்டு வருகிறது. குறிப்பாக கரோனா காலத்திலையும் புதுச்சேரி மிகச் சிறப்பாக செயல்பட்டது. ஏனென்றால் ஆளுநர் டாக்டர் ஆனதில்ல, டாக்டர் ஆளுநராக இருந்ததுனால. அதனால் நிச்சயமாக நல்லதொரு நிகழ்ச்சியில் கலந்து கொண்ட மகிழ்ச்சி. எந்தெந்த விதத்தில் இவர்களுக்கு உதவி செய்ய வேண்டுமோ அந்தந்த விதத்தில் இவர்களுக்கெல்லாம் உதவி செய்ய வேண்டும். என்னுடைய பங்கு இதில் இருக்கும். ஏனென்றால் அந்த துறையை சார்ந்த மருத்துவர் என்ற வகையிலும், துணைநிலை ஆளுநர் என்ற வகையிலும், பொது மக்களின் நலனில் அக்கறை கொண்ட நபர் என்ற வகையிலும், ஒரு மருத்துவர் என்ற வகையிலும் இந்த நிகழ்ச்சியை ஏற்பாடு செய்ததற்கு இந்த பாராட்டை நான் தெரிவித்துக் கொள்கிறேன். நன்றி, வணக்கம்.
மேம் நாங்கள் வந்து பல ஆண்டுகளாக உங்களை அப்சர்வ் பண்ணி நீங்கள் சொல்கிற டைரெக்ஷன்ஸில் தான் ஒர்க் பண்ணிகிட்ருக்கோம். நீங்கள் தோ யூ ஹேவ் பீன் அவே ஃப்ரம் த சிட்டி ஆர் சம்திங், பட் அண்டர் யுவர் டைரெக்ஷன் நம்ம டைரக்டர் ஸ்ரீராமுலு சார், this is a 1-year project which is culminating with the conference, but to have a continuous medical education initiatives. இப்போ நீங்கள் சொன்ன மாதிரி இப்போ வந்து இங்கே நம்ம கோட்டக் மஹிந்திரா பேங்க், கார்கினோஸ், ராஷ், அப்புறம் சனோஃபி, அது போல் மற்ற ஆர்கனைசேஷன்ஸ் இதில் சேர்ந்து இது ஒரு கண்டினியூ மெடிக்கல் எஜுகேஷன் ப்ரோக்ராமாக பண்ணுறோம். இன்ஃபேக்ட் நீங்கள் சொன்ன பாயிண்ட்ஸ் எல்லாம் இன்னைக்கு கான்ஃபரன்ஸில் ஃபுல்லாக டெலிபரேட் பண்ண போகிறோம். வி ஹேட் அ ஜஸ்ட் CXO பேனல். இந்த டாபிக் வந்து வாட் இட் டேக்ஸ் டு கார்பரேட்ஸ் டு சேலஞ்ச் த ஸ்டேட்டஸ் கோ, வாட் ஷுட் பி டன் டு பிரிங் இன் பேரடைம் ஷிஃப்ட் இன் தாட் ப்ராசஸ், CR and CSR, impact funding and insurance. இது வந்து ஜஸ்ட் CEOs ஆஃப் வேரியஸ் ஆர்கனைசேஷன்ஸ் ஆர் டெலிபரேட்டிங். அப்புறம் வந்து we have Dr. Arasar of ICH, Tamil Nadu, who created the genetic center in Tamil Nadu. He is going to be a speaker here, and Dr. Arasar is here. And avaroda idhula how to create a center of excellence in Puducherry, and national rare disease policy, how it is going to support. அப்புறம் prophylactic treatment, நீங்கள் சொன்னது முன்னிலையே சப்போர்ட் பண்ணுங்கிறதுக்கு how prophylactic treatment or prenatal diagnosis and registry and protocol guidelines across the Puducherry state. அது ஒரு பேனல்ல under Dr. Arasar we are going to deliberate. And then molecular testing, நீங்கள் சொன்ன மாதிரி உங்களோட ஸ்பெஷாலிட்டி, அதில் coordinated efforts and screening also across Puducherry state, what should be done. We have Dr. G. Srinivasan, Dr. Reena Gulati, அப்புறம் Mr. Suresh Venkatramani deliberating on this topic. And the next one is afterwards awareness creation, as you said, and corporate sensitization. It's not only public awareness, we have corporate leaders who will sensitize amongst their employees, which is a first step towards that. And how to get CSR contribution towards segment of rare disease, ma'am. இப்போ CSR we are funding lot of places, but can we allot one particular part of it to rare diseases? That is our initiative which we want to focus towards this care. And then idhula vandu we have Mr. J. Vijay Kumar, who is the ISTD Chennai chapter president, Mr. H. Raja, who is the honorary secretary for NIPM, which is a national HR body where across the India the HR corporates are part of it, and we'll be deliberating with it so that this team of people will take the message what you just delivered and will start implementing on that. And once again I request you to give a big applause for Governor for coming all the way from Telangana and delivering this address. And your energy keeps us to go more, and we'll roar towards, Puducherry will roar towards being a leader in rare disease management. That is our initiative. And I request to raise for national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा, विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा, तव शुभ नामे जागे, तव शुभ आशीष मांगे, गाहे तव जय गाथा, जन गण मंगलदायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे.
organizers and Mr. Sridhar, for taking this initiative to organize this very important conference, because it is, it is much more important. It's all the more important to have this conference at this juncture, since we all must be knowing that it has been almost 2 years since the government of India came up with the rare disease policy. And it had proposed, CSR support for the treatment of some rare diseases, including lysosomal storage disorders. And incidentally, February is also, commemorated as the International Rare Disease Awareness Month. So it has, there cannot be a perfect time to have this event. So thank you again for taking this initiative. So to briefly introduce myself, I'm Suyog, I'm from Mumbai. I work as the secretary of a patient advocacy group called the Lysosomal Storage Disorder Support Society, which is a non-profit organization based in New Delhi. And it is the first and leading patient advocacy group, which is solely dedicated, for lysosomal storage disorder patients in India. And it was established in 2010 by the parents and caregivers of LSD patients all across India. And I also work as the director for the International Gaucher Alliance, which is another non-profit organization representing the interests of Gaucher patients, which is another kind of lysosomal storage disorder. So it represents the interests of such patients and patient organizations worldwide. And I'm also a part of some panels of experts and international working groups such as the RDI and WHO Collaborative Global Network for Rare Diseases. And last but not least, I'm also a patient myself, so I'm affected by a lysosomal storage disorder called Gaucher disease, so which is one of the most prominent lysosomal storage disorders. So to give you an overview of what lysosomal storage disorders are, so they are basically a group of over 50 very rare, life-threatening, inherited metabolic disorders, which are caused by mutations of certain mutations in the genes, and they have a combined incidence of 1 in 7,000 people worldwide. Although individually they are much more rare, but as a combined group, they are caused by mutations in certain genes, which result in the deficiency of specific enzymes in the cells of the body. And this accumulation in the cells causes the cells to enlarge and dysfunction, which can also lead to a range of other symptoms and even fatality if it is left untreated. So the onset of symptoms in lysosomal storage disorders is usually in the early childhood, and majority of patients are diagnosed in the pediatric. Majority of patients exist in the pediatric age group. So at present, out of the 50 LSDs known, there is treatment available only for 7 odd LSDs. And some of the most common LSDs that are found in India include Gaucher disease, Pompe disease, Fabry disease, and mucopolysaccharidosis, or MPS. So talking about the impact of LSDs on patients and families, so it causes, first of all, the physical impairment. So the most typical symptoms of LSDs include enlargement of the organs like spleen and liver, skeletal abnormalities, joint contractures, bone pain or bone crisis, muscle weakness, and even long-term health problems like organ damage. They also cause intellectual and developmental disabilities. So many of the LSDs also affect the nervous system, which also affects the cognitive function of the patients, and it affects their ability to learn, communicate, and perform everyday tasks. Also, it has a very social impact and emotional impact on the patients and their families as well, because dealing with such kind of disorders leads to kind of isolation and low esteem among the patients. It also causes financial burden because, as you all know, the treatment for rare diseases is quite expensive. And apart from the main treatment, they also need special care and other special needs, which can take a financial toll on the family. And it also leads to financial burden on the caregivers because, as I mentioned, it requires many special needs, and so which can cause physical, emotional, and financial stress on the family members as well. So at present, there are 3 main types of treatment options. So the most widely used treatment option all over the world, which has been widely used and it is also proven to be very effective and safe, is enzyme replacement therapy. So this basically involves administration of the deficient or missing enzyme that is present in the body through intravenous infusions to the patients every 2 weeks. And it is a lifelong treatment because being a genetic problem, the enzyme needs to be replaced all throughout the life because the body is not able to produce it naturally. And another recent form of treatment option that has come up is substrate reduction therapy, which is only available for Gaucher disease as of now, and it is approved only for adult patients. And in India, it is currently available only for a select few patients. And another upcoming treatment option that is under research is gene therapy, which can provide a potential one-time cure or treatment option for genetic disorders. So speaking about the transformative effect of the treatment, so as I mentioned, I'm a patient myself, and I was diagnosed with Gaucher disease at the age of 4 back in 1996. And I was, in fact, the first patient in India to be diagnosed with Gaucher disease and also to receive treatment. And it came after much difficulties and delay. So I suffered from anemia and a massive enlargement of spleen and liver, as you can see from the first photo on the left. So there is a massive enlargement of the abdomen because of the enlargement of spleen, which hampered my normal activities as a child. I could not go to school or go out to play like any other normal child of my age. But fortunately, after a few years, my family got to know about a treatment option offered by a company called Genzyme Corporation back then, based in the US, which is now Sanofi Genzyme. And they offered a treatment in the form of enzyme replacement therapy for Gaucher disease. But when we got to know about the treatment, my family was again taken aback. The cost of the treatment, it again came as a shock because the treatment for such disorders is no way affordable to any ordinary individuals. But fortunately, I got this treatment, free of cost through the humanitarian aid program of the company. And since then, I have been getting this treatment consistently. So as you can see, I have shown a remarkable and rapid improvement with treatment over the years. And it's not just me, but most of the patients who get this treatment are able to live a very normal and productive life on treatment. We have examples of many patients who have become MBBS doctors, CAs. They have even gone on to start their own businesses. And we even have patients who have been in the merit list of the state boards in class 10. So it shows that this treatment not only helps the patient survive, but it also helps them lead a very productive and normal life. So talking about the challenges faced by the patients, so there is a general lack of awareness about rare diseases amongst the healthcare professionals, general public, and even the policymakers. And as a result of the lack of awareness, there are even diagnostic delays. And the contributing factor is that many of the LSDs have very non-specific symptoms. So there is limited, access and there is limited access of diagnostic genetic testing and other specialized diagnostic tools in the country. So which also adds to the diagnostic delay. And as I mentioned, the cost of LSD treatment, and it is a lifelong treatment. And in India, currently there is negligible support, although the government has come up with a rare disease policy for the treatment of such disorders. And all over the world, this treatment is supported by government in reimbursement and public insurance schemes. So there is no country in which the individual patients can afford this treatment. And also there is a social stigma and discrimination associated with these disorders because particularly in rural places where there is a general lack of understanding about these conditions. So all these challenges gave birth to LSDSS, and it was formed with the objectives of creating a sustainable long-term funding mechanism for the treatment of LSD patients, and also to raise awareness and education through various initiatives like observing the International Rare Disease Day, various disease-specific awareness day like Gaucher Day, MPS Day, and so on. We also conduct various other educational activities like CMEs for the healthcare professionals and media awareness campaigns for the awareness of general public and the policymakers. Apart from that, we also provide provide support and resources to families who are affected by such disorders. And our aim is also to promote early diagnosis and treatment, because early intervention can really help the patients lead a near normal life. So LSDSS was the first patient organization in India to start observing the International Rare Disease Day. And since then, we have been observing it consistently all over the last 12 years, even this month. So we have plans to observe it across various cities in India. So LSDSS has also achieved many milestones in the last 12 years. So we were able to get treatment for some patients in states like Karnataka and Kerala through the state governments, through judicial intervention in such states. And we have around 40 LSD patients currently being treated through such government interventions. And LSDSS was also instrumental in the national policy for rare diseases, because it is actually after a court case that was filed by LSDSS in the Delhi High Court that the Delhi High Court directed the central government to come up with a policy for rare diseases. And we have also been recipient of various international recognitions, such as the Global Gene Champions of Hope Award. So speaking about the current scenario and situation with respect to LSDs, there are currently around 600 known LSD patients in India, and out of which around 220 patients are getting treatment through charitable access programs of a couple of pharmaceutical companies, including Sanofi Genzyme. And through LSDSS intervention, some PSUs, armed forces like the Indian Army and ESIC have also initiated treatment for a few patients and their dependents. So around 50 patients, as I said, are getting treatment through the judicial intervention and through state governments. But the remaining patients, which is a substantial number, is still without any support. And the National Policy for Rare Diseases has identified 11 centers of excellence all across India. These centers of excellence have been involved in the treatment of rare diseases and LSDs since the last many years, and they have extensive experience and expertise in treating such conditions. So, under the policy, the government group 3 disorders, which includes LSDs, which need lifelong treatment. But clearly, as we can all understand, crowdfunding cannot be a sustainable and a practical solution for the treatment of such disorders, because if it can work for one-time treatment, like for something like SMA, which requires a treatment of say 16 crores, so that can possibly be funded through crowdfunding. But a treatment but a disorder like LSD, which requires crores, like several lakhs to crores of rupees of treatment every year, crowdfunding may not be feasible for such disorders. So speaking about the current donations that have been received on the Government of India's crowdfunding portal, so as you can see, the total donations collected is a very meager amount. So for over 450 patients that are registered on the portal, there are currently an amount of only 202 lakhs that has been raised through crowdfunding, so which is clearly not working, as we can see. So besides the need for raising awareness and other things like improving diagnostics, there is also a very crucial need to work towards the prevention of LSDs, because as we know, there are in India there is a practice of consanguinity which is quite prevalent in some parts of India, especially in some southern states of India. And speaking of Puducherry, so according to the National Family Health Survey, which came out last year, there is a rate of consanguineous marriages of almost 19% in Puducherry, which is much higher than the national average of 11%. And it has been scientifically well established that consanguinity considerably increases the risk of genetic disorders amongst the newborn babies. In fact, as per estimates, almost 40 to 50% of all the new patients that visit the centers of excellence with a genetic problem have a history of consanguinity in their families. So there is a clear need for prenatal screening and genetic counseling for such cases. And I would, urge the medical community, especially the gynecologists and the obstetricians, to make sure to, check for such history of consanguinity within the families. And if there is any such history found, then they should be recommended for genetic counseling or prenatal screening. So speaking about the role of corporates among, with respect to the treatment for LSDs, so as we know, the government has come up with a one-time support, but it's clearly not enough for treating the lifelong conditions. And there needs to be a sustainable and long-term funding mechanism to support such disorders needing lifelong treatment. And the corporate companies have a very significant role to play here to enable, access to such treatment through the CSR initiatives. So this can be done by collaborating with the centers of excellence, perhaps by supporting the treatment of some individual patients or maybe a group of patients from a particular COE. And also when we think about the impact assessment of the CSR expenditure, we need to look beyond, just the cost benefit analysis. Because when it comes to rare disease patients, we do not have the numbers. So if say an amount of 10 crores can maybe support 100 patients of malnutrition or some other disease, then that amount may only be sufficient for treating, say, 10 or 20 patients of LSDs. But that does not mean that we should be overlooking those few number of LSD patients, because their life is as important as anyone else. And if all the stakeholders, start looking only towards the cost-benefit analysis, then these patients will have, nobody to look for help. So impact should also be considered, considering the quality of life improvement that is brought by the treatment to the patient's life, and also the outcome, that is how the patient, how the patient's health gets transformed with the treatment, and what he can achieve in life with early intervention of treatment. So yeah, so with this message, I would like to end my talk, and I would again like to thank the organizers for taking this initiative, and I hope we can, replicate this in all other parts of India as well, so that we can, make the other stakeholders in different parts of the country as well aware of this social issue. Thanks a lot.
So you can be seated. Seated here. Thanks a lot, Sio. And your talk is the moment of truth of this conference and the actionables what we should do. Now we heard somebody from Bombay. We have a person who is based in Puducherry, and we heard from a patient, but let us hear from a patient of a mother. And her name is Ms. Jayalakshmi, who is the Secretary of Hemophilia Federation of Puducherry. And what is the parents' voice and how they handle and what the challenges they undergo. I request Ms. Jayalakshmi to come to the stage. Let us give a big hand for her, because every day is a challenge for them.
எல்லாருக்கும் வணக்கம். இங்கே பேசுவதற்கு எனக்கு வாய்ப்பு கொடுத்த ஹெல்த் கனெக்டுக்கு இங்கே விமென்ஸ் குரூப் சார்பாக பெரிய தேங்க்ஸ் சொல்ல கடமைப்பட்டிருக்கேன். ஐ எம் ஜெயலக்ஷ்மி சக்திவேல், ஹீமோஃபிலியா சொசைட்டி பாண்டிச்சேரி சாப்டர் செக்ரட்டரி. ஐ எம் ஏ ஹீமோஃபிலிக் மதர், கேரியர் விமன். எனக்கு 11 இயர்ஸில் ஒரு பையன் இருக்கான், 16 இயர்ஸில் ஒரு பையன் இருக்கான். இப்போ 11th ஸ்டாண்டர்ட் படிச்சுட்டு இருக்கான். ஹீ இஸ் ஏ ஹீமோஃபிலிக் எஃபெக்டான பையன். இப்போ 16 இயர்ஸில் படிக்கிறான் அப்படின்றது ஒரு சாதாரண விஷயம். ஆனால் ஹீமோஃபிலிக் மதராக நான் அதை கடந்து வந்த பாதைகள் ரொம்ப பெருசு, ரொம்ப அழுகையும் சோகமும் நிறைஞ்சிருந்துச்சு. அவன் 3 months பேபியாக இருக்கக்குள்ள, இதுக்கு முன்னாடி என்னுடைய என்டையர் ஃபேமிலிலையும் 3 members இருக்காங்க. அதாவது எங்கள் அண்ணா பையன், 2 அண்ணா பையனுங்க, வேறு பசங்க. எங்கள் அண்ணா பையன் இப்போ மெடிசன் கம்ப்ளீட் பண்ணிவிட்டு, பிம்ஸ் ஹாஸ்பிட்டலில் மெடிசன் கம்ப்ளீட் பண்ணிவிட்டு பிகம் ஏ டாக்டர். அவன் என்னுடைய பையன் சிவியர், அவன்லாம் மைண்டில் இருந்தால் இவன் ரொம்ப சிவியர். இவன் 3 months பேபியாக இருக்கக்குள்ள இவனுக்கு ஹீமோஃபிலிக் வரும் அப்படின்ற அவேர்னஸ்லாம் எனக்கு தெரியல. இது ஒரு ஜெனட்டிக் ப்ராப்ளம்னவே எங்களுக்கு தெரியல. அது என் பையன் பிறந்த பிறகு தான் அது இது ஜெனட்டிக் ப்ராப்ளம், இது தாய் வழியாக இது எஃபெக்ட் ஆகுன்றதே எனக்கு தெரிஞ்சிச்சு. அப்போ அவன் உடம்புல வந்து ஒரு ப்ளூ கலரில் பாஞ்சாக மேலே ஒரு பேட்சாக இருந்துச்சு. அது என்னவா இருக்கும், ஒருவேளை எங்கள் அண்ணி சொன்னாங்க அது ஹீமோஃபிலிக்காக இருக்கும், டாக்டரை மீட் பண்ணி பண்ணோம். ஃபஸ்ட்டு டயக்னோசிஸ் சும்மா டெஸ்ட் எடுக்கும்போதே அவன் எங்கேயோ ஒரு கையிலேருந்து ஒரு டெஸ்ட் கொஞ்சம் பிளட் எடுத்தாங்க. எடுத்துகிட்டு நான் வீட்டுக்கு போக்குள்ளே அவனுடைய கை வந்து இந்த பொசிஷனே இருக்குது, இதுக்கு மேலே எல்லாமே கருப்பாகிடுச்சு, அவனால் மூவ் பண்ண இப்படியே தான் இருக்கான். ஒரு 3 months பேபி, பயங்கர அழகாக அந்த மாதிரியே இருந்தான். திரும்ப மார்னிங் காலைல ஒரு 6:30க்கு 7 o'clockலாம் நாங்கள் ஹாஸ்பிட்டலில் வந்துட்டோம். கண்டிப்பாக சர்ஜரி பண்ணி தான் அதை ரிமூவ் பண்ணணும் அப்படின்னு சொன்னாங்க. அப்போ ஹீமோஃபிலியாக்குன்னு எனக்கு வந்து கன்ஃபார்ம் ஆச்சு. பட் என்னுடைய என்டையர் லைஃபுமே அதில் ஒரு சோகம் மட்டும்தான் இருக்கும், அழகு மட்டும்தான் இருக்குது அப்படின்னு நான் வந்து ரொம்ப கஷ்டப்பட்ட காலம். டாக்டர் நளினி அப்போ தான் நான் மீட் பண்ணேன். என்னுடைய லைஃப்பில் இருந்த சோகத்தெல்லாம் நீக்கி எனக்கு நிறைய கவுன்சிலிங் கொடுத்தாங்க, தைரியம் படுத்தினாங்க. நீ பார்த்து பண்ணுறதுனால தான் கடவுள் எனக்கு இந்த மாதிரி குழந்தைய உனக்கு கொடுத்துருக்காரு, நீ கண்டிப்பாக பார்த்துக்கலாம் ஜெயலட்சுமின்னு எனக்கு வந்து நம்பிக்கை கொடுத்தாங்க. நானும் என் பையன் நல்லா பார்த்துக்கிட்டேன். அப்போலாம் ஃபேக்டர்ஸ்லாம் கிடைக்கிறது ரொம்ப கஷ்டமாக இருக்கும். டாக்டர் வந்து அது வந்து அதிக அளவுக்கு பர்ச்சேஸ் பண்ணி எங்கள் பேஷண்ட்ஸ்க்கெலாம் கம்மியான விலையிலையோ இல்லை ஃப்ரீயாகவோ அவங்க நிறைய கொடுப்பாங்க. கொஞ்சம் வெல்லோ ஃபேமிலி இருப்பாங்க, மிடில் கிளாஸ்லேருந்து வருவாங்க, அவேர்னஸே இல்லாதவங்களாம் நிறைய பேர் இருக்காங்க. அதாவது இது ஜெனட்டிக் ப்ராப்ளம் தெரியாமல் 3 குழந்தையெல்லாம் பெற்ற பேரண்ட்ஸ்லாம் எங்கள் சாப்டரில் இருக்காங்க. வளர்ந்து பெரியவன் ஆன பிறகு தான் இது ஹீமோஃபிலியா, இதுக்கு ஃபேக்டரி யூஸ் பண்ணுன்ற அவேர்னஸ் இருக்கிறவங்களாம் எங்கள் சாப்டரில் இருக்காங்க. ரெகுலர் அட்டண்டன்ஸ் இருக்காது என் பையனுக்கு. மெனி டைம்ஸ் லீவுன்னு இருக்கும். ஸ்கூல் ரெகுலராக போக முடியாது, எல்லா குழந்தையும் மாதிரியே இருக்க முடியாது. ஒரு குழந்தை 1 வயசுல நடக்குன்னா என் பையன் வந்து 3 வயசுல தான் நடந்தான். ஏன்னா விழுந்தா இடிச்சுப்பான், எங்கே வேணா ரத்தம் வரும், மண்டையில் பல்லில் எங்கே வேணா ப்ளீட் ஆகும். ஸோ அதனால் அவன் 3 yearsல தான் நல்லாவே வாக் பண்ண கற்றுக்கிட்டான். ரெகுலர் அட்டண்டன்ஸ் இருக்காது. இதுக்கு என்ன பண்ணலான்னு இருக்கும்போ ஜிக்மரில் கூப்பிட்டு எங்களுக்கு ப்ரொஃபிலாக்ஸ் கொடுத்தாங்க. 2 years ப்ரொஃபிலாக்ஸ் கொடுத்தப்போ ஃபேக்டரி 8 ப்ரொஃபிலாக்ஸ் கொடுத்துருந்தாங்க. அந்த 2 years கொடுத்துருக்கப்போ அவனுக்கு வந்து முன்னாடியே ப்ளீட் ஆகிறதுக்கு முன்னாடியே கொடுத்ததுனால அவன் வந்து ரெகுலர் அட்டண்டன்ஸ் எந்த பிரச்சனையும் இல்லாமல் போயிட்டு இருந்தான். அது ரொம்ப சந்தோஷமாக இருந்தது. அப்போ தான் எங்களுக்கு தெரிஞ்சிச்சு ப்ரொஃபிலாக்ஸ் இருந்துச்சுன்னா பசங்க எந்த பிரச்சனையும் இல்லாமல் லைஃப்பை மூவ் பண்ண முடியும் அப்படின்ட்டு. இப்போல்லாம் கூட எக்ஸாம் டைம்லாம் கூட எங்களுக்கு நிறையா, அதாவது வேர்ல்டு ஃபெடரேஷன்லேருந்து எங்களுக்கு நிறைய ஃபேக்டர்ஸ்லாம் அவைலபிலிட்டியாக இருக்குது. எக்ஸாம் டைமு சிவியராக இருக்கிறவங்களுக்கு, எக்ஸாம் டைமில் இருக்கிற பசங்களுக்கு 11th 10th 12th அந்த மாதிரி பசங்களுக்குலாம் நிறைய கொடுத்துட்டு இருக்கிறாங்க. அது இல்லாமல் எங்கள் இதில் இருந்தே நிறைய பசங்க படிச்சியும் இப்போ ஃபாரின்லாம் போகிற அளவுக்கு நிறைய முன்னேற்றமாக இருக்காங்க. இதுக்கு ஒரே வழினா அவேர்னஸ் இல்லை. நிறைய பேரண்ட்ஸுக்கிட்ட அந்த ஃபேமிலியில் அவேர்னஸ் இல்லை. மேரேஜ்க்கு முன்னாடி கேரியர் டிடெக்ஷன் டெஸ்ட் எடுக்கணும் அப்படின்றதும், ப்ரெக்னன்சியாக இருக்கும்போது ப்ரீநாட்டல் டயக்னோசிஸ் பண்ணணுன்றதும் அவேர்னஸ் கிடையாது. நாங்கள் நிறைய பேருக்கு திரும்ப சொல்லியிருந்தோம். அவங்க வந்து அதை பொருட்படுத்த மாட்டாங்க. நமக்கு இருக்காது, நம்ம குழந்தை நல்லா தான் பிறக்கும் அப்படின்ற ஒரு மூட நம்பிக்கையிலே இருக்காங்க. செகண்டரி வந்து அவங்கள டாக்டர்ஸ் நிறைய ஹாஸ்பிட்டலாக நிறைய வரும்போது இந்த இவங்களுக்கெல்லாம் வந்து அவேர்னஸை ஏற்படுத்தணும். அப்புறம் என்னுடைய விமென்ஸ் குரூப் நிறைய விமென்ஸ் இருக்காங்க. இதில் எங்கள் சாப்டரில் நிறைய விமென்ஸ் இருக்காங்க. எனக்கு டாக்டர் கொடுத்த கவுன்சிலிங்கில் இப்போ நான் வந்து எங்கள் சாப்டரில் இருக்கிற 300 விமென்ஸ்க்கு நான் கவுன்சிலிங் கொடுக்குற அளவுக்கு நான் தைரியமாக இருக்கேன். அது இல்லாமல் சவுத் ரீஜன் ஃபுல்லாகவே நான் விமென்ஸ் கோஆர்டினேட்டராக இருந்திருக்கேன். என்னுடைய தைரியம், என்னுடைய குழந்தை நான் எப்படி வளர்த்தனோ அதுக்கு நான் விமென்ஸ் கோஆர்டினேட்டராக இருந்திருக்கேன். ஹெச்எஃப்ஐயில் நிறைய மீட்டிங்லாம் அட்டென்ட் பண்ணுறேன். இங்கே நான் முன்னாடி என் குழந்தை பிறக்காம மட்டும் இங்கேருந்து கோயிலுக்கு கூட நான் தனியாக போனதில்லை. ஆனால் என் பையன் பிறந்த பிறகு நான் தான் அவனை பார்த்துக்கணும், நான் தான் தைரியமாக இருக்கணும். இது டெல்லியில் இருக்கிற மீட்டிங் கூட நான் தனியாக போய் நான் ஹேண்டில் பண்ணுறேன். கார்டு வந்து என் பையன் வந்து எனக்கு கடவுள் கொடுத்த கிஃப்ட்டு தான். நான் என் பையனுக்கு ஹோம்ஒர்க் சொல்லி கொடுக்கும்போது நிறைய விஷயங்கள் அவனுடைய கிளாஸ்லேருந்து அவனுடைய பாடத்துலேருந்து நான் லேர்ன் பண்ணியிருக்கேன். இருந்தாலும் நான் சொல்லி கொடுக்கும்போது எனக்கு தெரியாத விஷயங்களை நான் கற்றுருக்கேன். அது மாதிரி தான் என் பையன் பிறந்து எனக்கு தைரியத்தையும் மற்றவங்களுக்கு ஹெல்ப் பண்ணுன்ற ஒரு ஐடியாவும் என் பையன் கொடுத்தான். அதனால் என் பையன் எனக்கு ஒரு காட் கொடுத்த கிஃப்ட்டு தான். தேங்க்யூ.
இல்லை, நீங்கள் வந்து தேங்க்ஸ் ஃபார் யுவர் டாக். உங்களோட ஒரு மதர் சைட்லேருந்து சொல்லியிருக்கீங்க. பட் இது வந்து நீங்கள் அழுகிறதுங்கிறதும் கிடையாது. இது என்னது, ஒரு டைமண்ட் கிரியேட் ஆகுதுன்னா ரொம்ப ப்ரெஷரில் தான் கிரியேட் ஆகுது. ஸோ அந்த மாதிரி நீங்கள் இருக்கிற சேலஞ்சஸ்லாம் கடந்து வந்துட்டு இப்போ இவ்வளோ பேருக்கு உதாரணமாக இருக்கீங்க. ஸோ ரொம்ப நன்றி, உங்களுக்கு பாராட்டுக்கள். பட் இதில் நீங்கள் வந்து உங்களோட எக்ஸ்பீரியன்ஸில் இப்போது பாண்டிச்சேரி மாதிரி இதில் இருக்குது, சிட்டியில் உங்களுக்கு வந்து நிறைய அவேர்னஸ்லாம் இருக்கும். பட் ரூரல் வில்லேஜஸ்லேருந்து இல்லை கிராமத்துலேருந்து வர்றவங்க எப்படி உங்ககிட்ட இன்ட்ராக்ட் பண்ணுறாங்க, இல்லை நீங்கள் எப்படி ஹேண்டில் பண்ணுறீங்க அதை?
சிட்டி, அதாவது இங்கிருந்து ஒரு 30 கிலோமீட்டர்ஸ் தூரத்துலேருந்துலாம் நிறைய பேர் வராங்க சார். பஸ் வசதியே இல்லாத கிராமத்துலேருந்துலாம் இங்கே வராங்க. நாங்கள் அவங்களுக்கு வந்து எப்படின்னா, அவங்க மெடிசன்ஸ்லாம் செல்லது, அவங்களுக்கு வந்து விமென்ஸ்க்குலாம் செல்ஃபி இன்ஃபெக்ஷன் நிறைய ட்ரைனிங் கொடுத்து வச்சுருக்கோம் சார். விமென்ஸில் நிறைய எங்களுடைய சாப்டரில் இருக்க ஆல் விமென்ஸும் செல்ஃபி இன்ஃப்ளூயன்ஸ் பண்ணுவாங்க அவங்கவுங்க பசங்களுக்கு. இப்போ எங்களுக்கு வேர்ல்டு ஃபெடரேஷன்லேருந்து நிறையா மெடிசன்ஸ் கிடைக்கிறதுனால, ஆனால் அவங்க வந்து ஹாஸ்பிட்டலைசேஷன் போகக்கூட ஹாஸ்பிட்டலில் டாக்டர்ஸ் அவங்களுடைய ப்ரொசீஜர் மட்டும்தான் மெடிசன் கொடுக்க முடியும். பட் நாங்கள் செல்ஃப் இன்ஃபெக்ஷன் பண்ணுறதுனால அவங்க பேரண்ட்டுக்கிட்ட, தாய்மார்கிட்ட கொடுத்து அவங்க வீட்டிலே பண்ணிக்கிற அளவுக்குலாம் இப்போ முன்னேற்றம் இருக்குது சார். நாங்கள் அந்த அளவுக்கு கவர் பண்ணி வச்சுருக்கோம் சார். இப்போ
நீங்கள் வந்து 30 கிலோமீட்டர் நம்ம பாண்டிச்சேரிக்கு பக்கத்தில், பட் அதை விட தாண்டி ஒரு 100 கிலோமீட்டர் கிராமம், அதெல்லாம் எப்படி ஹேண்டில் பண்ணுறீங்க?
சார்
என்ன அவேர்னஸ் கிரியேட் பண்ணுறீங்க நீங்கள்?
அதான் பக்கத்தில் இருக்கிற ஹாஸ்பிட்டல்ஸ்லாம் இருக்குல்ல சார், பக்கத்தில் கவர்மெண்ட் ஹாஸ்பிட்டல், அதுக்கெல்லாம் நாங்கள் அவேர்னஸ் பண்ணி அங்கெல்லாம் மெடிசன் ஸ்டோரேஜ் பண்ணுற அளவுக்கு நாங்கள் போய் பேசிலாம். அங்கே இருக்க தமிழ்நாட்டில் மேக்ஸிமம் தமிழ்நாடு எல்லா மெடிக்கல் காலேஜ்லையும் இப்போ மெடிசன் அவைலபிளாக இருக்குது சார். நாங்கள் அங்கே கோஆர்டினேட் பண்ணி, நாங்கள் பர்சனலாக போய் பேசி அங்கே கோஆர்டினேட் பண்ணி அங்கே பண்ணி நிறைய மெடிசன்ஸ்லாம் கொண்டு வந்து வச்சுருக்கோம் சார்.
ஓகே, தேங்க்யூ. So hope you understood at least bit of it, though she was speaking in Tamil, but she was voicing the same like what you said. Now, according to you, like you have given us the points to work on, but how is that a person in a rural pocket? Because in metros the awareness is more. But what do you think we should go to the last mile reach in a remote place or tribal area, something we don't know, a lot of patients are there. But according to you or with your experience, what is that we have to do, go for the last mile reach?
So I think with respect to, because people in rural areas face much more challenges in getting their condition diagnosed, because in such places, obviously the healthcare professionals do not have much awareness about such conditions. And so, there should be awareness created about such conditions, especially in the rural areas. So there is not only, so this knowledge about and awareness about such conditions is not just limited to the metro cities or the urban areas, but it also reaches, the rural population and the healthcare professionals working there. Because most of these patients usually have to travel very long distances to, some center of excellence or some other major hospital in some nearby city to get their conditions diagnosed. And even if they do get the treatment, it may not be, if the patient is from a very, low economical background, then it may not be even feasible for him to travel that distance to get the treatment. So these are some things that need to be taken care of. And so I think we need to first start with creating awareness amongst the healthcare professionals in the interior parts of the country.
One thing what I understand from you is, one is the cash kind of support, but also the transportation is one of the support which you need when people are traveling. மேடம், இவர் என்ன சொல்கிறாருன்னா, உங்களுக்கு வந்து பல வகையான சப்போர்ட் தேவைப்படுது இல்லையா? கேஷ் மட்டும் ஒரு சப்போர்ட்டுங்கிறது கிடையாது, அது முக்கியம், மெடிசன் வேணும். இவர் என்ன சொல்கிறாருன்னா, ரூரலில் இருக்கிறவங்கள ட்ராவல் பண்ணுறதுக்கு சப்போர்ட் வேணும், அந்த மாதிரி இருக்கணுங்கிறாங்க. அந்த மாதிரி ஆங்கிளில் ஒன்று மெடிசன் இல்லாமல் உங்களுக்கு வேறு வகையான என்ன சப்போர்ட் இருந்தால் உங்களுக்கு கிடைக்கும்?
வேர்ல்டு ஃபெடரேஷன்லேருந்து சார், அதாவது ஃபினான்ஷியலாக ரொம்ப ரூரல் ஏரியாவில் இருக்கும், ஃபினான்ஷியலாக ரொம்ப வீக்காக இருப்பாங்க சார். அவங்களுக்கு படிக்கிறதுலேருந்து எல்லா ஸ்காலர்ஷிப்பும் நாங்கள் கொடுத்துட்ருக்கோம். இப்போ குழந்தைங்க இருந்தால் ஸ்கூல் ஸ்டடீஸ்க்கு தனியாக ஒரு ஸ்காலர்ஷிப் கொடுக்குறோம். அவங்க காலேஜ் போனால் அதுக்காக தனியாக ஸ்காலர்ஷிப் கொடுக்குறோம். அதனால் நிறைய விமன்ஸ் வந்து ஃபினான்ஷியலாக ரொம்ப வீக்காக இருக்காங்க. அவங்களுக்கு நிறைய பேர் அவங்க செலக்ட் பண்ணி அதில் நாங்கள் நிறைய ஸ்காலர்ஷிப்ஸு அவங்களுடைய என்ன பண்ணால் அவங்க முன்னாடி வருவாங்க அப்படின்ற மாதிரி ஃபினான்ஷியலாக நாங்கள் நிறைய சப்போர்ட் பண்ணிகிட்ருக்கோம் சார்.
ஓகே, இப்போது நாங்கள் ஒரு ரிசர்ச் பண்ணுறதில் இப்போ வந்து நிறைய பேர் இப்போ சுகாய் மாதிரி இன்டர்நேஷ்னல் லெவலில் ஒரு வேலை செய்ய ஆரம்பிச்சிருக்காங்க. பட் இப்போ இந்த நீங்கள் ப்ரொஃபிலாக்டிக் ட்ரீட்மெண்ட்டை நிறைய சொல்லிட்டு இருந்தீங்க. பட் ஆனால் சில இடங்களில் இந்த ப்ரொஃபிலாக்டிக் ட்ரீட்மெண்ட் வச்சு கான்டாக்ட் ஸ்போர்ட்ஸ், இப்போ நம்ம ஹாக்கியோ அல்லது ஃபுட்பாலோ அந்த மாதிரி ஹீமோஃபிலிக் பேஷண்ட்ஸே வந்து விளையாடுற அளவுக்கு வந்திருக்காங்க. அந்த மாதிரி உங்களுக்கு உங்கள் டெரிட்டரியில் ஏதாவது உதாரணம் இருக்கா? இந்த மாதிரி ஏன்னா முன் உதாரணமாக இருக்கிற மாதிரி யாராவது எக்ஸ்ட்ராடனரியாக பண்ணியிருக்காங்கங்கிற மாதிரி? ஓகே, சரி, we'll speak to doctor later. Thanks a lot. Let us give a big applause for both of them who have come over the challenges. So just a second, please listen. What I find is when we are physically fit and when we have everything in life, we feel that we came into working in this rare disease accidentally, but after coming into this, I feel that every day we should do more towards this, our self-improvement and also to the improvement of the patients here. And I request Mr. Varada to give a memento to our challenges. Thanks a lot for Mr. Varada traveling from Bombay. He is the head of government banking for Kotak Mahindra Bank. Thanks a lot. Thank you so much. So we have closed quickly, but because of we don't know when Chief Minister is going to come, but what we'll do is we'll close now here and we'll go for lunch and we'll assemble at 1:45 so that we have some time to manage the other panels. Yeah, hope it is fine, and thank you once again.
I'm sure are doing. But just a couple of them that I thought, I would share here, which I lead a particular set of community of people who handle the blind and the specially abled children. So a couple of weeks back, I started searching for specially abled trainers. So if anybody here knows anybody who does specialized training to instill confidence in people with special abilities, please come forward, and you can even share your coordinates. I would leave my number with, with Preeti ma'am and Sridhar. But these are a set of people today who have joined the mainstream. Like you and me, they have aspired to be in organizations. They've come into companies and they get, very badly treated, be it by their own fellow colleagues or by the superior or by the juniors. They become the object of ridicule and mockery. And today I want to stand and represent their cause. So when they just gave me 10 minutes, I said, why not share with you about how it feels when people have joined the mainstream in corporates and they come with different kind of diseases, cured, some not visible, some visible. So I'm sure many of us here represent the corporate teams, right? It doesn't matter which place we are located in. But I would urge through this forum for you all to please carry back the message that especially when you have people in your teams, in your organization, who come back having probably gotten treated for varied disorders, you might want to capture it at the point of entry, not with an intent of using it against them, but with an intent of supporting them. And today you have many companies which come forward to help, right? Some charge, some do not charge money. And if we can become the medium to help. So I had this gentleman who worked in the hotel industry. He moved on to join my company. We had an element of, what we call it, outsourcing. So people used to work, typically we call them the high-end outsourcing. It's not call center, right? We have an IT organization. We also had a BPS. So they were part of the BPS. As people would expect that they're diffident, they can't speak, right? It was nothing like that. They came forward, they were taught voice and accent training, and they blended very well in the mainstream. But trust me, it's not easy for them to speak for 5 minutes continuously. Because these people are people who are inherently very diffident. So if we have many HRs sitting here in this community, or if we have many medical fraternity, people who support and who can advise, I would urge that please come forward. Society needs more people to help these kind of lesser fortunate people. And they get to be an object of ridicule in companies. They don't get their promotions. They don't get their increments. It's a very sad state. But they work harder than any of us. And they are absolutely loyal and they're very sincere. So this is one set of people I thought I would place for deliberation as the discussions go on. Because they are people who are like us. It's just that they've gone through certain health disorders. And they need special help because some of them are not coherent in their speech. Some of them are not coherent in the way they manage multiple roles or multiple activities. So we will need to be that bridge to ensure that their roles are mapped adequately to whatever the organization has, which will support them and help them to come up. The second set of people I wanted to speak about are women. I'm very passionate about the cause of women. And I'm now talking here about women who have been again shunned by people around them because they just do not have it in them to come back to corporate after they've taken a career break. We talk so many things about glass ceiling. We talk about shattering the glass cliff. But trust me, all those end in the meeting rooms. They end in conferences like this. I would request and urge many of you to please take the cause of women forward, right? And I see at least 50% of my audience here in this chamber who are women. In any manner, if each of you can reach out with the each one, teach one, imperative, it will really help the cause of women, especially people who will not come forward and tell you that they have a problem. Diffident women, for varied reasons, right? Everybody doesn't have the same family circumstances, and everybody doesn't have the same upbringing or fortune. So if we are here today, it's because we are totally and absolutely blessed by the divine. And we carry with us certain torches which others are not gifted to have. We just heard the hardship that people, families of Suyog and the ma'am who would come here now, they went through. So can we be that beacon to help people out? Can we create many more Dr. Nalinis in our own sphere? Because I know each one of you can do it. Each one of you has it in you. It's just that first hurdle of how do I take that first step. There are many, many NGOs around who look to support from philanthropists because they won't be able to pay us for our time. And I have associated with similar organizations in Bangalore, in rural areas as well. And we are trying to bring these women back into the mainstream. There are physically abused women, there are women who have taken a maternity break, no money to start and upgrade their skills. They don't know how to come back to the mainstream, but they're talented nevertheless. So that's the cause of women that I wanted to speak about. And the third thing, if I have another 2 more minutes, is to sensitize youth. Because all of us have youngsters in our family. That's another cause which is very close to my heart. They are the future of this nation. I come from the Indian Air Force, where we grew up in the hills of this country with just nature as our best teacher. Right? And here I stand before you with that same sense of pride, because much of the discipline, much of the upbringing that we have seen, which has made us successful today, comes from that upbringing. Today's youth need people to show them the way. And they all think that, holding a high-end phone in their hand, just chatting away, posting their pictures on Instagram makes them a success. So if you all can, by way of your own connects, pick up the cause of youth in some manner. There are several youngsters sitting there not having direction on what to do. IT is not the end of the world. IT, information technology, is not the only thing which is bread and butter for many people. There are many of our friends, children probably, who lost the way. If we can support in this small humble gathering here, let's say we have about 60 people here, if we can take this message back and do something on our own volition, trying to groom them, to bring them out. I'm currently associated with some government schools. Up until 4 months ago, I never knew of this word called kulip. If any of you have heard of this word called kulip, please put your hands up. Yeah, I can see 2 people. I would like to connect with you when I'm off the stage. So we were told that there were some very meritorious children who couldn't complete or continue their education after the 10th grade because they got on to kulip. So the principal of the school, whom I met, and I volunteered to do something from the organization, she said, if you could get somebody here to counsel these youth and tell them why kulip is so dangerous, it will be an honor. Can you please help us? Then I came back and I Googled and I realized it's kind of a drug, right? It's like those little silica gel packets or sachets, which children tend to throw up to the roof because it just sticks up there when the teachers are patrolling the class. And some of them who are excellent, and very studious children had to discontinue their board exams because of this addiction called kulip. So when I look around and I see, whom can I get, somebody who can come and help out. We finally reached out to Kilpauk Medical College and we got somebody there from the Drug Rehabilitation Center to come forward and help. And the number of children, it's so sad, it's so very sad because our children are very fortunate, they have us. These are children who come from very underprivileged homes. Their parents are either, into plumbing or cleaning the roadsides or, they come from very, very sad homes, broken homes. So we engage in some small humble measure trying to uplift the lives of these youth as well. So I'm sure if you look around you, you will come across many such situations because this is a thought which often comes to me. We all go to corporate, we all dress well, we want to make a difference, but we don't know how to start that first step. If you can all connect with your own areas, localities, schools, institutions, I'm sure you'll come across many. NGOs are definitely a beacon and they will tell you where they need help. Today we need volunteers, we need helping hands. So please come forward, let's make the world a better place and let's make our own nation a much better place. Thank you so very much for hearing me out. Jai Hind.
I want to speak about the hemophilia affected children and the youth. These youth come up with great difficulty because of repeated bleeds. Some of them are not able to attend school for days together, even months together. Suppose there is an intracranial bleed, it takes about 3-4 months to attend, and suppose there is a psoas bleed. They can't walk, they can't go to school. They are despised by other children as well as the teachers. So they develop an inferiority complex. In spite of that, many of them come up. They have become, they become engineers, some of them are graduates, like that. But there is a definite difference between the urban and the rural. The urban youth somehow adjust, or from the higher socio-economic group, they are guided well and they adjust. But it's the rural and the lower socioeconomic children. They lack self-confidence. That is one thing about them. They all have a sense of inferiority complex, that we are not equal to others. That is one. Second is their own companions don't treat them equally. Third is they lack the language. If they have to compete with others, in various interviews and all that, because they study in the local language, either Hindi or Tamil, like that. So when they go and compete at the higher level, then they are not taken up. As such, they cannot take up every job. They have to take up only jobs where they will be able to manage themselves with their bleeds. That is one. Second is, some of them are called for training to urban areas. Even if they get selected, they are all called as trainees and they are all called to urban areas. There, they have to maintain themselves. They have to have a place to stay. Then initially, at least, they need the money to travel. Second is to go and stay there. They need a place, and then the training. After training, what happens? They also do know whether they will get placement or not. These sort of things bug my hemophilia boys. It's really difficult for them to find a job for what they have studied. For instance, I've got a postgraduate in mechanical engineering. The way he came up, I know he had to undergo some surgery. He used to get urinary bleeds all the time, and then he used to be repeatedly admitted. He had to undergo surgery, everything. So all these people cannot complete their degrees during the first time, because many of them have arrears because of the repeated failures. Sometimes during the exam, they have a bleed, so they will not be able to attend. These sort of things bug the hemophilia boys. We try to help them, but as far as jobs are concerned, we are not able to help them. They have to find a small job, and then many of them are not in the jobs they should be. That is why even software jobs are difficult for them to get. So I find a lot of boys are unemployed. I have no way of helping them out. I help them as far as they go for their education career. But after that career, we are not able to help them. And then getting married is another problem. Because they are hemophiliacs. But some of the boys, somehow they have a love marriage and get married. But after marriage also, once the girl knows that he has got repeated bleeds, he won't be able to manage, then they leave them and go. There are a lot of marital problems also for them. Even for the carrier, for the carrier girls who we know in the family that they carry the gene. When you tell them, marital problems are a big problem. They are not getting married because once they know there is a hemophilia in the family, the people don't accept them. So there is a social problem, and many of the mothers just hide the family history of hemophilia, and then they suffer. Because after that, their marriage separation occurs. When a child is born with hemophilia, then the problems start. So these are the social problems attending to hemophiliacs. Thank you.
Thanks a lot, ma'am. We'll certainly take this point as a conference note and we'll do what best we can do to find a solution. Thanks a lot. And lunch is ready. And request you to come by 40 minutes because we may expect Governor to come by CM to come by another 45 minutes. The lunch is there, sir. Please join us. For the next session, I request Dr. Parameshwaran to come to the dais. Mr. Parameshwaran to come to the dais. Dr. Murali, Deputy Director, Public Health. Dr. Arasar. Next slide. Dr. Vaibhav. Preeti, Dr. R. sir has to come. Oh, he's coming. Okay. Can you give mics there? Welcome Dr. R. sir to the stage. This panel is important in the angle of next segment, what we have to look in terms of how we centers of excellence, which is part of the national research policy, how we have to work on that angle. And for that, we have the stalwarts, Dr. Ara sir, who initiated that in Tamil Nadu in Chennai, and Dr. Murali, who is the Deputy Director of Public Health in Puducherry, Mr. Parameshwaran from Sanofi, and our Dr. Vaibhav from Jipmer. And as a prelude, where Dr. Nali Madam was there and our DMS entire fraternity was there, and with that inputs, we have created this panel. And I'll request each one of you to.
Good afternoon. My encounter with probably this rare diseases. Probably I've been working as an assistant professor, then professor from Institute of Child Health and Obstetric and Gynecology. So we've been seeing a lot of this babies born with several anomalies, and we had several group of mothers who lose their children very early in life. We have had a woman losing 10 children also, soon after birth. And we know them that they are inheriting certain genetic disorders that kills babies. So we were wondering as to how to help these mothers have at least one live baby. And that was time 30 years back when my knowledge on probably genetics, my knowledge on chromosomes, my knowledge on the disease itself was in the very nascent stage, primitive stage. Our professors would just touch on the subject, saying few names, and we used to go through textbooks with only a few paragraphs of that. And that was our knowledge was limited. But over the years, a lot of science has grown that started throwing more light on many of the genetic conditions. So we started understanding, and it was my passion to learn this just to show off. My initial learning was just to show off my co-colleagues and postgraduates as how learned I am, no? So I used to memorize all of these names and tell them just to frighten them. See, exams, they may ask you this, you have to be prepared. So they all used to be afraid of learning all these names from these names of the rare disease are all named after some English people or European people. And it became difficult even to pronounce those names. So that was what started as a passion of showing off. Slowly I started to see these mothers, they're suffering, no, to have a child. And that's how the interest started growing. Then I started slowly getting into the government fold. As I became a senior, the government started giving me certain roles of advisory and policy making, all of them. Then I used to tell them, there are so much mothers who several of the aspects of even doing an anomaly scan in a government setup, then doing a detailed study of their chromosomes, of their genes, all of them not available. And that time government was not prepared to outsource any of the things because government was working as a silo compartment, not allowing the government doctors to probably interact with the corporate groups. So if you having any connection with the corporate group, then you probably may get branded also of taking kickbacks. That was the days. Because I still remember as director of Institute of Child Health when Paramesh or Anil Raina used to approach us, government used to view me suspiciously. Am I having certain interest in their thing? because Sanofi Genzyme was one who helped me also learn, because their interest, though they are people who are into research, finding out drugs for rare diseases, and also bringing those knowledge to the public. When our association started like this, a lot of people started doubting our concerns also. So this was the situations that time. So slowly, when I became a director of the Institute of Child Health and became the state nodal officer for child health, suddenly I got the responsibility of interacting with the government on these rare disease policies, because at that time there was a case in the court of parents asking for help to the government, that the government should has the right to take care of the health needs of these a small section of the population who are suffering from rare disease also. So, but the government was not given proper data. So normally the data are picked up from the textbook. When we say there are 7,000 rare diseases, well, the government gets upset. 7,000 rare diseases. Oh, then it's a huge burden. They start working, all our IAS officers start working on statistics. 7,000 means they multiply into the population. See, it must be a huge burden. Then they call my predecessors, who are all seniors, who give data. They say, because the rare disease is not diagnosed, we are not confirming the diagnosis, we actually do not know the burden, because we did not have a registry also, because we did not have a diagnosis. We only, all of them are suspect. We used to suspect lysosomal storage disorders. We used to suspect Pompe's disease, any type of glycogen storage disorder, genetic conditions, all of them. But we did not have. But in the corporates, people who could afford, probably they were sending the samples to Delhi, Bombay, where by the time some labs were established, they were spending 23 to 40,000 rupees for each sample and getting things done. So corporate, the private setup did have certain number of proved cases. The government setup did not have any proved cases. So it was very difficult for us to give to the government data as to plan their financial policies. So it was that time that we started probably the group Genzyme and Sanofi came forward to help us in providing us free testing for enzyme assays. So now we had this help. Now we were able to bring all our rare diseases cases and then send them for enzyme studies. Now we started our own registry. By this time, we had a genetic department for long, but it was not functioning because we did not have a qualified geneticist. The government did not get a qualified geneticist to employ first. So there are no geneticists because they had good scope outside. So the departments were vacant, the posts were not filled up, the equipments that were all sanctioned were all lying idle, not being utilized. So it was that time I took up the challenge. I thought I must put everything to use. These are all monies that is given by the government for public use, lying idle. So what I did was find out from among my pediatric population who is interested in genetics, somehow coax them to send for small training programs and get them start the department. Though they were not qualified geneticists, I named them geneticists. I got the government name them geneticists somehow, because they need to answer the court also. The questions, as the court asking every time why you are not helping the child, what is your policy on rare diseases. At the time, the nation did not also have a policy. They were on the drafting that with the ICMR help and all the AIMS group, they were drafting this policy. And government now sent me to go around whole of India to every institute in India. So I went around every institute in India which is doing genetic studies. Then with government help, I came to know what all they are doing, how they are helping, how they are treating, where all facilities are available, and then put up a big file to be submitted to the government. It was this time that our health secretary, who was very eager, that he was a doctor, he was a veterinarian, who was very much interested in genetics also, his passion. So he told me, you need to quickly speed up and put up a genetic department in place. And when we started compiling data, then I became the director. I started presenting to the government at least a preliminary data. I told them the government need not be afraid. My health budget cannot accommodate all these things. I have priorities. I have anemia to treat. I have sickle cell anemia to treat. I have thalassemia to treat. I have hemophilia to treat rare diseases. Then where could I treat lysosomal storage disorder? You are giving me a budget for 20,000 crores like that. And I told them, no, sir. Actually, there are only treatment for only some 5 or 6 diseases. I think if we start, confirmed cases are now only 7 with me. Either it may increase day by day, but I think we could find finances. At least let's start helping at least the 7 cases that are having a proved diagnosis who are having a treatment. That's how we started. So at the time, national policy had come. The national policy, the central government wanted us, their health and family welfare wanted us to send the files of patients who needed this. So we sent 7 cases first. Then over the year, we added 4 more cases. It became 11. Now I knew that the case flow is not as much as everyone feared. So the number of storage disorders, though technically speaking, it looks huge number, but the ones who survive and become eligible for treatment are few. So what government did was started looking at it from different angle. So my secretaries of National Health Mission and all of them told me, Arsan, instead of spending on this treatment part, why don't we start preventing the birth of this simultaneously? So they started telling me, I will fund you for prenatal diagnosis. I will fund you to set up Center of Excellence for prenatal diagnosis. Now I have to put a new setup into place because all were working in silos. My obstetric department was working in silo, my pediatric department. Pick up a case after counseling that needs prenatal diagnosis, I have to send it to the Institute of Obstetrics, where technical expertise of doing that was not available and laboratory facilities was not available. So it needs to be outsourced. So I had to talk to the government that till the government sets up a laboratory facility, we need to outsource all the investigation, these genetic analysis outside. And we were drafting how to call about tender for this. And the quotes were too high. The government was delaying sanctioning this test into private labs. So people who are having private genetic labs will know how much it costs. And negotiating the government, I know how difficult it is on the pricing part of it to get it done. So it was looking huge, and they were thinking that the private organization, genetic labs, were probably siphoning off money on this. And so there was a doubt, aspirations created on these genetic labs. And the government also was not in a position to actually have a genetic lab in place. Because the initial investment cost is huge. So we had applied for a Japanese aid, because when things come on many times in the health sector, the Japanese grant is a huge grant we get for many of our programs. So the government asked me to write a grant for the WHO, the World Bank and the Japanese aid. So we were drafting that. By this time, because on the compulsion of the court, we had to set up our Center of Excellence and Genetic Lab, and it was established with the CM and Health Minister opening that, and cases started getting registered. And there was simultaneously the corporate sector, another organization which was also involved in treating these children with rare diseases. But government wanted this to be brought, except for enzyme therapy, which was costing. The government was willing to sponsor every other supportive treatment that a child needs. It's just not about enzymes alone. They need so many other supportive therapies like surgeries, transfusions, medications, all of them. The government was ready, and we were starting those supportive services. I think our LS come get admitted and get diagnosed, treated, and we were trying to find funds, and Sanofi is one organization we were funding. We were getting funding through different sources. That's how it all started, and we had our thing. And slowly the government recognized it as a center of excellence. It's not far off, because I was told that funding is available now after this COVID to set up genetic. The government is also keen in setting up a genetic lab. I think more and more cases will diagnose, but as feared, the number is not so huge and the financial burden may not be so huge as the government fears. And I think it is easy to get the CSR. But actually, when I was just trying to convince most of the Navaratna companies, that were having huge funds as CSR funds, that was the time this COVID outbreak also came. So most of the funds got diverted. The initial funds got diverted for calamities. Then the funds got diverted for COVID. I think everything is now over. I think now most of the huge companies, Navaratna companies, must be having sufficient funds to sponsor these children. And this probably is my brief encounter with rare diseases and how the Center of Excellence came into existence in the Institute of Child Health.
Thanks a lot, Doctor. You have answered all the questions at one go of this thing. Many questions, many answers. Now I would like to request Mr. Parameshwaran of Sanofi to say what inputs, for example, even Honorable Governor has told that we should have a Center of Excellence here. And what is your inputs or how we can go about, which it's not only for LSDs, but it can pave way for a lot of other rare diseases also. Yeah.
Thank you. Thanks for the opportunity, Professor Sridhar. I think we had a great opportunity to partner with Dr. Arasar in the Institute, and I think when we started off, I think sir, in 2017 end, that was a time when there was nothing. And I think from there to now, the journey of the last 3-4 years has been very exciting. And I think we have been able to play our part in ensuring that the timely support is provided, in terms of diagnosis, because we have been running a diagnostic support program for 5 lysosomal storage disorders since 2013. Because one of the things which happens is that when a family comes to the clinic and they are told that you have to do a diagnostic test and it would cost about, say, between enzyme and mutation would cost 20,000-25,000 rupees. I think that becomes a barrier for them to go to the next level. So one of the things which we identified early, and I think in 2013 we kind of started off providing free enzyme and mutation analysis, at least for those treatable rare diseases, so that at least there is a proof point of diagnosis. And that's something which we have been able to kind of offer, and we would encourage all the clinicians to avail of this. Our team is there and they can actually help facilitate that piece. The second area which we have been working on is, as Sir said, identifying a geneticist as such. So we've kind of partnered with the Society for Indian Academy of Medical Genetics to provide them a grant for a 3-month fellowship in clinical genetics. So our role ends with providing a grant. So there is this institution called Society for Indian Academy of Medical Genetics. There are about 7 centers in the country where this 3-month fellowship is provided. And these are for MD Pediatrics, MD General Medicine people. So the interested candidates could apply directly. And there are the board of clinicians who interview the candidate, and then I think the patient society has played a significant role over the last so many years. And I think it started with the state of Karnataka, and I think then Tamil Nadu, then Kerala, then Rajasthan, then West Bengal. These were a handful of patients who were there who actually needed timely support, and I think the respective state governments took up the challenge of providing them the kind of financial assistance. And I think in the meantime, the National Rare Disease Policy also came in. And the good thing, and I think it's a very important step that it has happened, is that they have also made a firm funding provision of up to 50 lakhs per patient for all rare diseases. And this is for treatment. And that's a very positive step. And also to build sustainability under Schedule 7 of the Companies Act 2013, they have also encouraged the centers of excellence to reach out to interested corporates and public sector undertakings to get the benefit of the 2% CSR, which is mandatory for all the corporates and the public sector undertakings. So one of the areas which is currently a lacunae is the bridge between the centers of excellence and the corporates and the PSUs. So because when we have spoken to each of them individually, the public sector undertakings are sympathetic to the cause, and the centers create over this 1 year, so that there is an opportunity for fund to flow from the corporates via their CSR to the centers of excellence. I think this is one area which we're kind of working on, and we aim to kind of continue to work with the corporates on this area. And one last point I would like to also share is that the government has now opened up 11 centers of excellence, and from whatever we could understand is that they are interested in having at least one center of excellence minimum in each of the states and union territories, say over the course of the next 12 odd months. And the other element also is within the state where the center is started, I think there is a need to have a kind of a hub and spoke arrangement, because it would be difficult for patients and caregivers to travel to the center of excellence every fortnight or every other week for consultation and treatment support. So one of the downstream actions would be, once a center of excellence is established, if there is a kind of a hub and spoke arrangement which can be made with other important 2-3 medical colleges, that would be the next step, which could ensure that there is continuity of support for the patients, and also it ensures that the burden doesn't fall completely on the center of excellence in the state. So that's.
See, I think the situations, when initially I was diagnosing certain rare diseases, I only know them as a disease without a diagnosis. So we used to exhaust all our clinical tests, laboratory tests, not knowing a diagnosis. I used to tell the patients, என்ன diagnosis-னே தெரியல, இந்த சாம்பிள் அமெரிக்காவுக்கு தான் அனுப்பணும், இல்லை பாம்பேக்கு தான் அனுப்பணும், கண்டுபிடிக்க முடியும் இங்கே. Even because Institute of Child Health is supposed to be one of the centers of excellence doing all the work. Sometimes we used to send them to Vellore. At that time, even CMC Vellore did not have all this facility. So many of the children were dying without a diagnosis, actually. Then the day comes when children had the diagnosis now. Oh, we were having this enzyme assays at least available in the private setup. People who can afford now had a diagnosis. And now they die with a diagnosis, but no treatment available. We'll tell them, this is a diagnosis, now no treatment is available. Maybe treatment is available in US, but becomes very costly to go to US and take this treatment. So, knowing the disease, the patient waits for death and then dies. Then a day comes when the drug also comes. Drug also now is available, and now the patient dies knowing he has a diagnosis, he knows there is a drug, but not available to him. See, this very pathetic stage. When he is dying, knowing that he doesn't know the no one, doctors all over the world don't know my diagnosis, I am dying, okay, no problem. When he knows the diagnosis, no medicine, humankind has not found a medicine, he also accepts that. But now, both cannot accept. A doctor also cannot accept when there is a disease diagnosed, a medicine is available, but he is not able to treat the patient. And the patient, because he is not able to afford, but dies because no help from the society in which he is living, that's very pathetic. I think we must realize the situation and do something, some method, either the government or the public or the public companies. I think all of us should join to help these children to live for whatever probably the nature has designed for them.
Thanks a lot, Doctor. Now further to the inputs of both our experts, one of the points that the child's mother spoke on hemophilic is if prophylactic care can be a way forward instead of the demand care. And then taking a cue from that, I am requesting Dr. Murali, who is the Deputy Director of Public Health Puducherry, and a lot of his team members are here, who are the primary health center people, that is the last mile reach, Dr. Where the sensitization, if it happens, one is diagnosis, as Dr. Rasar is saying, and one is the child's mother is saying prophylactic treatment should be the way when advanced methods are there. How can we go about, like one is center of excellence, and which will support an up and spoke, and also prophylactic care. If we can look into that, how do you think if we have to bring in that type of structure in Puducherry, what is the way forward or your views?
Good afternoon, everybody. I think everybody is feeling sleepy after the good lunch. If people are sleepy, please wake up. I think my voice can wake you up now. Thank you very much, sir. now I am speaking here as an administrator, not as a medical person, but an administrator who has some years of experience in the present administrative setup in Puducherry. My sir has told at least ICH has reached a stage where now they can diagnose, they know that some drug is available, and probably to some extent to some patients they are able to provide it. I will tell you the bare truth, in Puducherry we are at the point number 0 only, like still we are not in a position even to diagnose. I am telling you the truth, sir. So I am not going to say we have this, we have that. I am telling you the actual situation. Though we have very good institutions providing excellent medical care, tertiary medical care and all those things, still we have not reached a point where we can give a proper diagnosis to our affected patients. And only then the question of treatment and other things come. Fortunately for us, Dr. Nalini has been doing extensive work in hemophilia, and that is the only area we have done something thanks to Madam. And seated next to her is Dr. Reena Gulati. She is a genetics person. She joined our service. We couldn't give her any sort of support. And she left to JIPMER. JIPMER, I don't know what sort of support she is getting from JIPMER. I don't think she is getting even she is a DM genetics person. Remember, sir said he found out some people and told them that they are geneticists, but we really had a genetist. We had a specialist in genetics whose services we could not make use of. And even today, I feel even JIPMER is not making adequate use of our services. That is the real situation which is prevailing here. And so my request to this entire Health Connect and all the big corporates, giants who have come here, first thing is creating awareness, and leave alone the public. The awareness has to be created among our doctors. That is the truth. So that is why most of my PHC in-charge medical officers are sitting here. And the awareness has to be created in them first, because they are very good in dealing with common health problems. But many of them, when they were students, they would have never studied these chapters. And we have managed to pass our exams even without reading any of these disorders. So that is the truth. So our basic knowledge of these disorders only is very poor. I think today maybe they had an opportunity to rekindle their knowledge about these rare diseases. And so the awareness creation, I think, should start with creating awareness among our medical professionals. So they should be given some classes or training where at least they should be able to suspect that this child is suffering from a rare disease. Many cases what happens is the child comes to the particular, say, PHC or somewhere, maybe the medical officer misses it there and this goes on, and then the question of early diagnosis itself is lost. So the awareness creation stood before the public. I think it should start with creating an awareness among our own health professionals, have some training sessions or give them some ideas, tips, when to suspect a rare disease, how to, when they are suspecting a rare disease, what is the next step they should do, some sort of awareness creation for our doctors, sir. Next, I wish we could have, if we have a tie-up with the excellent lab sir has set up in Chennai, and if we have the facility at least to send our samples to their lab, probably it will be very difficult to set up a lab like a lab set up by sir in Chennai. I don't think that can happen in the near future in Puducherry, at least not in the next few months or years. So till such a lab is set up in this place, I think kindly help us to have a tie-up with, for us Chennai will be the nearest place. So if we can help us to have a tie-up with some labs in Chennai, private as well as the government side, that will help us to at least diagnose these diseases in the children in whom we are suspecting them. So at least the initial support can come from them. Probably later on, you can help us to set up a decent lab to diagnose, to do a proper newborn screening or some other useful tests. Maybe we don't require very advanced testing and all that, at least the basic testing, which is not being done right now. So if you can help us to do that, that will be very helpful for us. And then when a child is diagnosed, of course, now hemophilia, now madam is there, you can have, even during the first meeting, I requested you, if you have to do something in Puducherry, I think you have to do it with madam. So she has already done so much in hemophilia. Probably if you can help her, she can achieve much more in that area. And when it comes to this, I was reading the Centers of Excellence, Public-Private Partnership. Our experience has been very, I think I should tell you, it's a bad experience, because I will tell you the fact, when the funds come from both the sources, say from a private source and a government source, then to manage and take forward is very difficult, because every time a file is put up to a bureaucrat, a secretary, since the government is also contributing to that, then you end up facing all the red tapeisms again. Though a part of the fund has come from the private, the corporates have donated, say, 50%, the other 50% is come from the government side, but every stage we face a problem in executing the project, because the government officer will keep telling, we have 50% funds there. So you do it the way we usually do it. The government has a particular way of getting things done. And that method, I think in future it is not going to help us, it is not going to work. But they will continue to persist only with those methods. So they will keep insisting, our money is here, so you have to follow the government financial rules. This is what is happening right now. In any project, if there is a contribution from the government, the secretaries will always insist that everything should be done according to GFR. So as sir has faced the secretaries, when you write about this, that many times they won't be aware of the actual field level realities, and they will keep on asking us questions, and the project never really takes off. So here my request will be, if something has to be done, let it be 100% private, sir. Please don't link it with the government funding. Government funding, let it go on. Whatever little funds the government can provide for these rare diseases, let it provide. The fact is 70% of the budget the government allots for health will go off only for paying the salaries. So only hardly 20-30% of the money is left for building, improving our infrastructure or creating infrastructure or for consumables. So the budget is always for salary. So let us not go and mix it up with that situation. So my request will be, say, if you plan to do something, some good thing, you have to come out with a project. Let that project should be wholly funded only by the corporate, so that the government's procedural problems will not get into implementing this project. Say, if you want to buy today morning, Honorable LG Madam spoke about the X-ray machine which we got for this TB case finding. It was fully funded by the private organization. So we could get it and we could start the work. Supposing if a part of it had to be funded by the government, that would not have come at all. So my only request at this point of time is, at least for now, if the corporates come forward to help us to do something, let it be fully funded by them. In that case, I think we can go forward, take the things forward that will be more helpful. So, and my humble request now is, please let us start from the scratch. Help us to at least diagnose these rare diseases. Now let us discuss about treating these children or giving other benefits to these children. Of course, that should follow, but at least help us to put in place to diagnose these rare diseases and help us to create a registry for these rare diseases. In Puducherry, to tell you the truth, we don't have a registry for rare diseases. If some official asks us how many cases are there in Puducherry, right now we won't be able to give any proper data. So the next important step for our administration, I feel, is to set up a registry for these rare diseases and help us to at least start diagnosing these rare diseases in children. Thank you, sir.
I just want to add a few things of what you have told. One is spreading awareness to the PHC medical officer and all public health people. Now, in this contest, I want to thank Sanofi also, who had helped us in developing a set of faculty, whom they were all from the Institute of Child Health, who would go around different medical colleges and talk to the students and doctors there of what is these rare diseases, how to probably suspect them, what to do when they suspect, how to diagnose, all those information. This type of CME-like programs was funded by our Sanofi, and we had done a few of them. But many times, you know, we put up a timetable, but some other priorities take over. Suddenly we get an outbreak of a dengue like that, and all our other programs goes behind. We have to stop and then restart only after the outbreaks are over. So like that, we have had many such hurdles. But we have done a few, and Sanofi was all the time eager to support such type of thing. And regarding this public-private partnership, what Sarah has told, don't mix private money with public money. I'll tell you a few examples of the problems that I have faced when I take the CSR or NGOs who come to donate something for some services. And if you mix it, you end up sometimes with problem. I think we have to have some guidelines formulated, legal guidelines on this. Because when we had a lot of cancer children there, we had a lot of mothers staying with them, and we know how depressed and anxious they all be. So there was one suggestion of this medical clowning, and involving these children and the parents in all the activities like dancing, drama, putting up shows, drawing, painting, all that. So one organization came, they called Little Theatre. They told me, we'll put up a facility here where we can engage all these children so that we keep them mentally satisfied during their stay, during the course of their illness. So what I did was, I gave them the place in Institute of Child Health after taking due consent from the government that I was going to physically give them a place for setting up. So they make an investment there, building up the theatre. So after some time, what happens, this keeps on running for some times well. And now when a COVID outbreak comes, the hospital is in dearth of place. Now the hospital asked the place back for setting up the COVID ward. Now the person who has invested so much would not want to dismantle all the theatre-like facilities. Then the conflict comes. Now they go to court saying, we have invested in public interest so much money, the hospital suddenly is asking us to vacate, that we cannot do. Then they call me. Why did you allocate a space into a government setup for a private place? No, then I had to answer them. It was not that we couldn't answer the court or the superiors, but it puts you into a lot of trouble. You have to face a lot of these problems when you are allowing. So I think we can work out different models of how to do this. I think both can handle, but we have to have certain guidelines and legal models on how we can handle. One thing is the sponsor type. Suppose a child is diagnosed, they can sponsor the treatment, where the hospital is not directly involved. So there are several type models available everywhere. I think we have to look up those models and keep working on those models, both government and private hand holding and taking this costly treatment pay forward. Then regarding hemophilia, simple thing I'll tell you. One mother came to my room one day and requested, sir, my child is studying in school, he's having hemophilia. He needs to be given factor 8, but I am traveling all the way from a rural place in Chengalpet district to Institute of Child Health in Chennai. And the school's getting absenteeism regularly. So could you give me this drug? I'll take it and give it there. Now I get a recommendation from my senior also, who is in the power. She's saying, that patient is known to me, why don't you help them? Then I told there is no hospital rules where I can give the drug and send to the patient. So our government rule doesn't permit giving a drug to the patient. So we give tablets to them and send. But there is no rule where I can give a costliest drug to patient and send them home to get his IV administration. Then I call up Chengalpet Medical College and tell them, see, there is a patient, I'll give the drug. Because they did not have the drug. I am having surplus of them, these factors. So I tell them, I will give the drug, let the parents take it and take it in Chengalpet Medical College. But there the doctors ask me so many questions, the dean asked me so many questions. Is there some way I can receive this? Actually, the drug should come through my pharmacy, only then I can dispense. I cannot directly entertain a drug brought from outside to be administered in my hospital campus. Suppose something goes wrong, who is to answer? All these types of doubt comes. So I have to convince those dean and their HOD saying, I'll take the responsibility. Because I was a state nodal officer, I had the power to issue instructions. So I write a letter that the Institute of Child Health will take up the responsibility of guiding the doctors. If any untoward accidents also, they can be shifted to ICH if some untoward reaction comes. So after giving that assurance, then they are administered the drug. But it entails a lot of these problems. And the patient next requests are that the hospitality is not very nice. Every time they are looking at as something troublesome. Why don't you give the drug to me? I will go and take it in a private hospital close by. Now, I did not have any model to look at till I went to All India Institute of Medical Science. There in the genetic department where they are administering this enzymes for rare diseases, their HODs told me that they are sending the drug with the patient to be administered about 200 kilometers away from AIIMS in some private hospital. So the drug is taken. See, the drug is very costlier than a factor 8. That itself is given from an All India Institute of Medical Science to be taken by the attender who is coming with the authorization to take the drug in with product form in thermocol box, take it to the local doctor whom they identify as some family physician like that. They get the certificate. They talk to the doctor to know whether he is aware that how this drug should be administered, all instructions are guided. Then the patient takes that and takes the thing. And the child and the parents and the family are avoided that long distance of 200 kilometer travel expenses, all this thing. So I come and talk to our minister telling him, sir, this request has come and the patient is asking like this to give the drug to be administered in a private hospital. The minister tells me, okay, no problem, why don't you give it? Now I ask my secretary, says, be careful, don't get into any problem by doing this. Then I call the private hospital where they want to take sir, tomorrow no problem should come for me. Suppose they identify, because all this bottle will carry a label, Tamil Nadu Arasu supplied by Tamil Nadu government. Suppose they see these drug bottles in my campus the public health people are doing an inspection. And they see this, they will think that I am doing pilferages and getting the drugs into my setup. So I want a clear written note from you saying that this drug was given along with the batch number, all this. So I don't think many people would take all these pains to do that. So, but for this patient's sake, I had to take this also. Then I told the doctor, private doctor, no, I will, to a nursing home, I will issue a certificate that these two drugs with the batch numbers are given by Institute of Child Health to be administered for the child in that hospital. So I had to do that. Now I had to send a copy to the government also that I am following a different modus of operandi that is not there, already there. Because I am afraid of my auditing also. Later I should not be audited for some wrong procedural lapse. So it takes a lot of time, it takes a lot of perseverance, it takes a lot of out-of-way thinking and courage to do certain things. I think people who want to help must develop the attitude of courage to help. I think that's one lesson I have learned during these things. I think these are all models. Hemophilic children losing their schools, all of them is very much, the amount of money they spend for a travel becomes actually more than the cost of the medicine itself several times. So I think we have to sit with the government, and I think we have to formulate certain guidelines of helping children, where probably making it very easy for getting this drug administered.
Thanks a lot, Doctor. If you look in, our agenda was how to create paradigm shift on the status quo. You have said a lot of points, and I would like to put again administrative question to Dr. Weber, and also some highlight on SME and other things which you highlighted on the pre-conference meeting. Now, one thing is, how is it different for you from the state perspective? You heard Dr. Arasar, Dr. Murli and all. How do you think from the central perspective? You work in JIPMER, and how is that things for you in that angle?
Yeah, I will try to give the detailed the thoughts I have been having for last few hours. So first I will start from what is rare. We have been using this term rare. So WHO code says 1 per 1,000 patients or 10 per 10,000 patients as rare. So even if we take that 1 per 1,000 margin and then put the denominator as our Indian population, I am not sure what the number will be. And then we are talking about which rare disease. We are talking about rare diseases, right? So if some disease is having X prevalence, other disease is having Y prevalence, if we take all this together, then this rare further comes down. So the administrators can have that vision ki what the rare has been used term may not be that rare. The number may not be that small as the word connotes. Because there is a basic hurdle for telling the administrators and the policy makers that these numbers are very less. So that number is not that less, number one. Number two, in fact, while going through that policy, I came to the term called as orphan. So there is a curious phenomena I had run in my MBBS also, this orphan drugs and orphan diseases. They came short and hesitant while calling the patients themselves orphan. But actually it is the patient who becomes the orphan in these all terminology. So what is happening here is orphan here means that the disease number of patients is so less that no pharma company is interested in putting in the money for the research. No policymakers are putting in the policies for them, and no politicians are interested because the numbers are again so less. Nobody is bothered. So actually the patients are there, they are the orphans. So one additional thing that can be done to bring the patient out from that ambit is to show that number is not that less and the problem is not that negligent. And if we give them treatment and show humanitarian approach, then the message goes that we are kind at hearts, and that itself gives a benefit. So what do I mean by all this, combining all these things? So let me start with the management part. The biggest hurdle, the first hurdle the clinician faces is somewhere around 12,000, 20,000 rupees is needed to make a diagnosis. Till that diagnosis is made, none of the policy will be applicable to the patient. I know that this is a case of muscular dystrophy. I know that this is a case of spinal muscular atrophy. I am almost 80% sure. But the bottom line of all the policymaker is, it should be 100%. And then you bring that test, and the genetic test costs around 20,000, and the other test will come around this cost. So I think one of the basic paradigms we should improve is this. The implementation should start as and when the doctor suspects that this is a, as Dr. Murli was saying, I think he also said a similar thing. Why the hell the patient should pay for the whole exome sequencing if you are going to make a policy in that regards? So that is the first thing where we should come. Then there comes the diagnostic challenge. Diagnosis has multiple connotations. There can be pre-diagnosis like at the screening level or at the suspected level. Unfortunately, I don't think screening level it is possible, because again the numbers are less. So if you put it in the screening level, you start screening all the children, it will not be financially redeemable. But however, once we suspect the disorder, that can be done. And the beautiful part is that it need not be available at every center or every policy. I will tell, till now the JIPMER it is not available. But what we do is we just send the sample to NIMANS and they will give us the report. Even if a nominal charge is taken, then it will be, the charges will be less. It will not be 20,000 or 12,000 it comes in the private sector. Even if we can bring it up to 2,000, 3,000, 4,000, we can tell this patient that this is not an emergency. Even he can arrange this money in next 3 months, 6 months, 4 months. I have seen many patients coming back just after telling that. Once we tell them this needs 16,000 for diagnosis, they will say, oh, Baba, I cannot do it. But we say, can you arrange 16,000 in next 1 year? They will say, yes, sir, that I can do. Then they will come back in next 1 year. That can be done when we can have nodal center. As Dr. Reena was telling that, many of these equipments, many of these things are available at the center. The problem is not only availability of the lab, the problem is of keep those labs running. And there comes the two issues. One is manpower. So can government and private institutes and corporates can come together and say that, okay, the corporate institute is paying this person 20,000, 30,000 per month and he will remain with you and do your diagnostic work. That will be great help. Can corporate sector or the government can give a chunk of the lab investigations, the chemicals and all those things needed, consumables needed, and then it can be done. The per se establishment of lab is not difficult. I think Dr. Reena will highlight more once it comes to her talk. So that is the point. The third point is treatment, which has again 3 components. One is stabilizing the current patient. Second is reducing the progression. Third thing is cure or totally preventing it. The third part is what we have been highlighting it, but it is not available, I am telling you. Even if you talk whatever the drug medicine, they will reduce the progression or stabilize the disease. We can do a lot on stabilizing part and the reducing the progression part. Can we give this patient ICU PS? Even if you give a ICU care, it will be huge help. Ventilator support, can it be given at home? Can it be given? Can the patient be given a ventilator if and when he needs? So all those things are the issues, and then comes these very costly drugs, which cost will come down as we give to more and more patients. Currently, we are talking that it is stuck. Patient is not able to use that 16,000 rupees, and we are talking that prevalence of 1 per 35,000 of SMA, 3,500, 1 per 3,500, I think, if I am not wrong. But this prevalence is when we are not diagnosing the cases, when the patient is not affording. Suppose somebody takes charges, if the diagnosis is easily available, then this prevalence will go up.
Next step will come in.
So that is the next step. And the thing of beauty of this approach is that many of the things and most of these disorders, many of the things are really, really common. Does SMA, hemophilia, I don't know, muscle dystrophy, myotonic dystrophy or other dystrophies or any of these things, do they need different rehabilitation program? I don't think. A single huge rehabilitation lab can cater all these patients. So can we do that? Can we bring them under the rehabilitation? A genetic counselor will be needed common for all these disorders. So why do we talk about only single disorders? This will be common for all disorders. Can we add a gynecologist and physiotherapy department and a physiotherapist to our pool? That will be the further help, I think. And by these techniques, we can bring down the finances. but it will be a challenge. That being said, and that corporate and government sector has to come together, and public forum also has to come together. The only, as the patient said today just before in this talk, only the crowdfunding is not going to help. Crowdfunding to how many? Crowdfunding to how many patients and how many people? That will not help. That will help only to a success. So what we need is humanitarian view. Center of Excellence is a good thing that we are going ahead, but it should not remain only in the books, and it should not remain only in the namesakes. This is Center of Excellence. It should be really excellent. And a common thing which will be definitely needed to all these things, will need to bring the IT sector together and make this, convert this everything into a national registry. If we have a national registry for all the disorder under a single umbrella of rare disorders, it will have hemophilia, it will have SMA, it will have lysosomal storage disorders, it will have everything under that gambit. That number will be in lakhs, if not crores. That will reduce the thing, and that sort of vision we need to have. So a lot of money spent here at the registry level can bring down cost at many other levels. So these are my few suggestions and opinions.
Thanks a lot.
Comments. Thank you.
So I think as you were talking, something came to my mind which I had shared earlier. But generally what happens is we feel with our heart and think with our head. So somewhere, I think in this discussion since morning, I think it's somewhere, I think there is a need to link the head and the heart. Because when you talk to an economist in the government setup, he would be thinking with his head and then start doing all the mathematical thing. Even with half-baked mathematical information, like you said, like for example, a classic case is, if you were to take a case like diabetes, we'd say there are 9 crore patients with diabetes in India, prevalence. But how many of them actually take insulins, which is the standard of care? Between private setup, government setup, free insulin which is provided, it does not exceed 5 to 6 lakhs. And how many of these 9 crore diabetics have been diagnosed? And every hospital or nursing home worth its salt has HbA1c and all the bells and whistles which they do. Even after that, that thing is not fully diagnosed. So therefore, I think one of the things Dr. Arasar said is a very pertinent point, is that what is it that is available with us? There are 7,000 rare diseases. Even after so many years of research by many pharmaceutical companies, the total number of treatments which are available globally does not exceed more than 350 out of 7,000. So technically we have 6,750 rare diseases for which there are no treatments. Second is, out of these 350, in India you have approved treatments which are about 18 or 19 of them by the Drug Controller General of India. So the point that we need to kind of really look at is that how do we localize the problem? Second, what is it that we can show as proof points that there is a mechanism which can work in a country like ours, and then scale that mechanism. So because otherwise it is like I mean, to use an old phrase, it's like a black elephant in a dark room with 6 blind men. So, I mean, there will never be any solution for this. But I think somewhere, if we can kind of start off and show proof points, I think it might really help. And I think the biggest proof point is that the government of India, in a country of 1.4 billion, has chosen to recognize rare diseases and come out with a policy. They have chosen to come out with allocating 500 crore per patient, which I think is a very bold and a positive step. I think we need to kind of pick it up from there as a team, and it's like I say, it takes a village to raise a child. I think all stakeholders, I mean, we as corporates, I think he was talking about diagnosis. I think it's important that companies which are in their respective therapeutic areas actually should step up to the plate and provide, and I'm making a bold statement here, provide free diagnosis support for those diseases, like for example, which we did and which we continue to do. And I think that's important, that companies step up to the plate. If I am in X disease, then I think it is my responsibility to work with the stakeholders and provide free diagnosis support for them. Because no person, as sir rightly said, no person would kind of be able to spend 20,000, 25,000 rupees for a diagnosis. And as sir said, they say that, okay, come back after 1 year when you cut off 25,000, by the time the child would have died. So I think if you are really kind of, you can say, feeling with our heart and thinking with our head, I think it's important that we do that. And I think it's important for companies in this area to step up to the plate. That if I am in SMA, if I am in DMD, if I am in whichever other disorder, do I have a concurrent diagnostics program which I will offer free of cost to the respective? So that would at least cover the treatable disorders which are there. So I think that's a positive step I think we should kind of start.
Thanks a lot, doctor. Now in this angle...
Now can I add some more thing?
Okay.
You know, Down syndrome, no, most of you, 20 years back, 10 years back itself, because I was working in an obstetric unit where 18,000 deliveries, I know we have babies born every day, one baby with Down syndrome. But we were not able to give them a definitive diagnosis because karyotyping was not available in our government setup. We have to refer them to a private lab where this karyotyping was costing them around 2,000 to 3,000 rupees. That was looking bad. A patient who comes to a public facility, for them this 2,000 to 3,000 is a huge money, huge money. So when I became director, I thought I must set up at least this karyotyping to be done in a hospital to at least help diagnose some of the chromosomal disorders. Now, I had a pathology professor, Dr. Papati, who was very eager to help me in every way. But she told me, sir, we need first some reagents. Now, I did not have any producing to buy these reagents because the funding for that is not available. Now, I looked up, then I saw there is one fund not much utilized for NCD, non-communicable diseases. Then I called my administrative officer and asked him, sir, can I buy reagents for this thing from this NCD? Then my administrative officer tells me, no, this is only for diabetes and hypertension. Then I take the GO and read it again. See, it's written for non-communicable disease. Where it is written only for diabetes or hypertension? Because one health secretary, previous health secretary had taught me to go through GOs very carefully. Kindly read for all the loopholes there first. If you are going to go to higher post, kindly read the loopholes so that anything you do, you can escape from there. So now I read the loopholes. Now I told me it's written NCD. Now this Down syndrome is an NCD in the truest sense. So you just put, don't write anywhere for Down syndrome, put NCD drug in the whole of the proceedings and get me that drug, get me the reagent. Now the professor next tells me, sir, I need a cytogenetist to interpret it. Now then I look at my GO. My GO would, the powers that was vested would only provide me to give 15,000 rupees for me to employ. But no cytogenetist will come for 15,000 rupees per month. And they were demanding for part-time cytogenists, were demanding 30,000 from me to come and interpret that. Now at that time only Rotary Club, when the clubs come to us, asking what I can do for your hospital. Then I told one of the Rotary Club, madam, you need not buy me anything. I want you to sponsor a cytogeneticist who can help this Down syndrome. Kindly sponsor their monthly salary, 30,000 rupees part-time. I can have this karyotyping done. Now, after starting that, I think the department is going to now finish their 1,000th karyotyping. So much of children we have helped, just putting a few things into place. I think it needs a lot of out-of-box thinking to bringing together cohesively into something, because now at least I can have a definitive diagnosis for all the suspected Down syndrome, because sometimes certain features overlap and we wrongly diagnose clinically as Down syndrome, label them as Down syndrome, they'll be going around as Downs. Some clinical features may not be adequate, so Downs will be going up as normal children, only to be got beaten up by their parents or teachers because he is not studying well. So all this will stop probably if we have a definitive diagnosis. And simple thing was karyotyping, as Sarah told. ICH is offering karyotyping free for anyone who comes to ICH. Even anyone can approach. Any institution, PHCs can send their samples to ICH. their karyotyping will be done free. We have 2 tandem mass spectroscopy, and I have made arrangements to buy all the reagents. We can have all the inborn error of metabolism, all the 42 diagnosed, and that is also free for every person in Tamil Nadu. So I think Puducherry also can utilize that facility which is available in ICH, where tandem mass spectroscopy is done free for diagnosing all the inborn error of metabolism and the karyotyping also.
This is the power of Health Connect, I think.
So just 1 minute. What sir has said is also doable, because the problem is of reagents and all the chemicals. And second thing is, in many of these disorder genetic tests specifically, Dr. Reena will be more better person to have to comment. A single test can diagnose multiple disorders like limb-girdle muscular dystrophy, congenital myasthenic syndromes, and the congenital myasthenic dystrophies, multiple disorders. Only single whole exome sequencing is needed. So whole exome sequencing will need an array of multiple disorders.
So next panel is going to be completely on that.
So yeah. So that's it's not like each test, each disease needs one separate diagnostic test. That message has to go to the administrators also. Okay, it is only this one test we are asking, and in that everything will be covered. But relevant reagents will be needed.
Perfect. Yeah. One of the things I take a cue, and I am taking an exception in asking Dr.
Yeah, but that being said, the setup is same. The reagents needed are multiple. The things needed may be different. Yeah.
Certainly, we'll elaborate in this in the coming next panel. And since one of the things is how to connect with the resources available, one of the major takeaways is how you connect the resources available. Let it be private or Rotary Club or a corporate. How is that we have to network and do is one of the critical things. And in this angle, I'm going a little bit away because Dr. Murli was saying awareness for the primary health center doctors and also a registry and protocol guidelines. In fact, since we have been working for last 1 year on partnerships with various organizations, today one of the documents that was given by Roche team to DMS is on that angle. If you can throw a few highlights on this point of registry, protocol, whatever you are thinking, with what you have done in other states can be evaluated. Monica. Sorry, I'm just bringing it because I saw some work being done in that angle.
Okay, thank you. Thank you, Dr. Sridhar, and thank you for this question. What I would like to focus here is because I heard everyone from the government, from the private sector, state, central, and one of the things that really strike me oddly here is, as much as we talk about collaboration, as much as we talk about partnership, how much really do we trust each other when it comes to sitting across the table and really bringing those topics for discussion? We always keep saying public-private partnership, but if there's something that COVID has taught us is like partnerships of all sorts, public-public, public-private, private-private partnerships. They all came together, and that is what we were able to solve for the crisis, right? And in that regard, when I think about hemophilia, I think about rare diseases, what Dr. Weber also said, it's not just about one disease. You enable the healthcare system, and that system will take care of many other diseases as well. So and I'm a trained public health specialist myself, so I've seen that in my own practice in the med school. When you go to the community and when you talk to the community people, how much are they really aware about hypertension, diabetes? Forget rare diseases, forget hemophilia, which is maybe a last mile for them, right? So what it really requires at the first level is health promotion, awareness. And this is one of the things we as an organization also care for, that what we want to do is to enable the healthcare system enough that the system is mature to take care of prevention, diagnosis, early treatment, and then rehabilitation. And that is why in our own doing in some of the states of India, be it like Rajasthan, be it like Goa, the smaller state, be it like Madhya Pradesh as well, is what we are doing a lot of community empowerment. We are doing awareness sessions, not only for the community, but also for the healthcare providers. Because I'm not sure many of the colleagues who are sitting from the primary health centers, how much are they aware of diagnosing hemophilia? And of course, it's not possible at a primary health center, but if a patient is repeatedly coming with bleeding, sometimes epistaxis, sometimes joint bleed, how many times we often think of maybe this patient needs to be referred to a higher center for more diagnosis. Sometimes we're just happy looking at reflexes that a baby is crawling is all fine, but maybe not looking at if the baby is just inconsolable in terms of crying all the time. If the baby is not able to hold the neck, maybe he has SMA or any other muscular dystrophy. But are we picking up those signs very early in life? And that is why the role of primary healthcare providers is very important. And the other thing that you mentioned, registry. What we are also doing in one of the states is that we really created and when I say we, it's about a collaboration, not just us. We've created a database in terms of not just how many patients have hemophilia, but also doing a comprehensive assessment of the quality of life once they were put on treatment. So it's not just about who has the disease, but it's also about what has been his journey on the treatment. And that is also bringing a lot of cue for us for early intervention in the patient's disease pathway. And that is what we as, from the other side, I'd say from the corporate side, want to help support not just government, but other stakeholders in the healthcare system to come together and really come with a comprehensive solution. It cannot be all about diagnosis and then you have diagnosis but no treatment available. It cannot be about you have treatment but you don't have diagnosis in place. It's all about we need to come together as one team to do prevention, promotion, diagnosis, treatment, and adherence to the treatment. So this is what we want to work with you on. Thank you.
Thanks a lot. And we have to go to the next panel, Doctor. And thanks a lot for the wonderful session. I think each one of you gave one of the points to work on. Network is net worth, which can make a big difference in this rare disease management. Thanks a lot to each one of you. I request Mr. Ganesh to come and give a memento to our Dr. Parameshwar, sir. Yeah. So. And I request Mr. Anil Raina to come to the stage to give mementos to team. Yeah. Ganesh, give it to Dr. Vaibhav. Dr. Anil to Dr. Adar, sir. Sir. Dr. Monica to Mr. Parameshwaran, please. This is developing the network now. Developing the network. And I would like to give it to Dr. Murali because he has been so supportive, and whenever we go, he gives us such a comfort that we see a different personality or administrator in the government side.
Too many facets to say. Yes, sir. Thank you, sir. Thank you very much. Can we have a group photo? Yes.
We'll quickly proceed to the next panel. Dr. Gulati, Reena Gulati, please come to the stage. Dr. Srinivasan, sir.
He's there. Yes. We are missing Ms. Sanita Srinivas. I request Dr. Monica to come in. Suresh of Karkinos. Okay. You can pitch in his place. Might be Suresh has got a call from the DMS and that's why he has gone. He's not here. But still, we have stalwarts here. We'll take up the panel. And yes, I will. We'll take the cue from what went out from the last panel, and we have gone into how the policy should be frameworked, then what is the center of excellence, and now we have come to the next level saying, we heard patient's story, and now we are getting into a level where molecular testing is one of the best cues that has been voiced much, and we have heard you speaking on that in the pre-conference meeting also. So I would like to request Dr. Reena to start with her comments.
So, good afternoon, everyone. I am thankful to the experts in the previous panel to set the ball rolling, and a lot of important things have already been said. In fact, most of the important things have already been said. I thank Dr. Murli to bring up how the things started and the time when I was with General Hospital and then in maternity hospital. Actually, I started a genetic clinic in General Hospital 20 years ago. And since then, we have come a very, very long way to now in 2023. There was a time when I was the only person in Puducherry and surrounding Tamil Nadu to be talking about genetics. Now we have a room full of people who are stakeholders. It's wonderful. In a very small place like Puducherry, there are so many other stakeholders all over India. And that is how we have come to a stage where now even the government has recognized that genetic problems are very important problems. At that time, people used to think I'm crazy because when I did my MD pediatrics, every pediatrician wanted to become either a neonatologist or a pediatric intensivist. So I was the crazy one who went into genetics, probably too early because we didn't have any facilities at that time. But then if nobody took it up at that time, then we wouldn't have come to this stage. I have been told for the past 20 years, what are you doing here? What are you doing in Puducherry? If at all you wanted to stay in India, why didn't you go to USA? With your qualification and experience and whatever. So my answer always used to be, I don't want to treat Americans. I am passionate about children. That is why I came into pediatrics. And I'm passionate about children with genetic disorders. That is why I took up genetics when everybody else took up neonatology. So much for that. But when I started the genetic clinic, the main thing was I kind of used to maintain a register. What I came to know was that genetic problems are not rare in this part of the country. And that register used to get filled up very quickly. But the most help that I could give them was tell them why it has happened, what is it, and most of the time that not much can be done. But still it made a difference to the people to know why it is happening. There is a concept of God punishing people by giving a genetic disorder in the society. People have a lot of explanations why it happens. And a lot of things have been said about awareness. Every single family, every single patient that you speak to have a story on which a novel can be written. So we have been neglecting these patients beyond concerns of humanity. So we are lucky that now we have come to a stage where so many stakeholders are there who are caring for these children. Not only children, we have a lot of adult patients with genetic diseases also. Till now, the whole focus was on cancers. Cancers were the celebrated disease, though every patient with cancer also has a lot of problems. It's a difficult time for the family. But here are patients who probably are more in number than the patients who have cancers. We have recently, we means I have a student, a PhD student. We have gone into the public, house to house. This student was a PhD student for mine. We took all permissions from government of Puducherry, which were thankfully granted, very helpful. We have gone to the doctors in PHC to get their impression about what problems they face, whether they are able to pick up children or patients with genetic disorders. So it has been a very enlightening experience. We find that approximately 7 to 9% households have patients with genetic disorders. This is Puducherry. 7 to 9% is not a small number. So my first fight is with the numbers and so-called rare diseases. Rare diseases are not rare in India, especially with us where we have a lot of consanguinity. All this has already been discussed. I actually have taken up this point in big forums, national, even international. But the thing was that it has a political connotation, so the term rare diseases cannot be done away with because that is what gets funds. It fetches funds. So we have to live with the term rare diseases, but they are definitely not rare in India and definitely not in this part of the country. So that is one point. Second is bringing about awareness is the most important thing that we need to do for anything to go further. Bringing awareness, as already speakers have said, both to the public and to the physicians. The physicians, the family physician, the physician who is the primary contact physician. My student had actually contacted many of the medical officers who man the PHCs in Puducherry. I'm not sure if somebody is there who might have come in contact with him. So we found that they feel that they do not have the kind of training that will help them to pick up patients with genetic disorders. And definitely genetic disorders are not rare. So previous panel, it was discussed that there are some courses, like a 3-month course that can be done. So all these are very, very welcome steps where we can make the primary contact physician pick up genetic disorders and refer them to an appropriate place. They don't only need to know when to suspect a genetic disorder, but also need to know where to send the patient. So that is a very, very important part, bringing awareness. And that is also something that can be picked up by so-called PPP and CSR. The second point is availability becomes much later. Accessibility. Unless we make everything accessible to people who need it, all our efforts are useless. We may manufacture ERT, we may bring down the prices, whatever we do. Unless we make it accessible to the people who need it, it's not going to be much useful. Accessibility is also, first you have to diagnose, then only you can treat. So how to bring, what we found during our research work was that there are people in rural areas who do not have access even to come to Puducherry, leave alone anywhere else. They have never even gone out of their village. To the extent that some of the patients we found who had some genetic disorder, my student used to make them sit on his bike and bring them here so that we can take them up and help them out. And then the word goes by mouth. Then there were other people in that village who came to know that there is something that can be done. So bringing awareness and accessibility are the first two stairs of the ladder. We cannot reach the top unless we scale these two stairs of the ladder. And then whatever initially you had put up some suggestions, it is extremely important. All the steps are important. We have to have more and more treatments coming up. We say these are incurable diseases. Genetic disorders are incurable. Why spend so much time, money, effort? But my question is diabetes curable? Is hypertension curable? They are not curable. They are manageable. So similarly, genetic disorders also, some are curable, others are manageable. And the list of curables and manageables is increasing every single day. So I think they deserve as much attention and care as the so-called very, very rampant problems like hypertension or diabetes. Coming to the availability of facilities in Puducherry, Dr. Murli had brought up a very important point. I would like to inform that we do have laboratories in Jipmer. I myself have developed a new laboratory for molecular tests in Department of Pediatrics, though we are not a lab department, with funds, research funds obtained from DBT. These funds did not come for genetic diseases from the institute because institute has to look after many things and it becomes difficult to provide funds to multiple departments for different things. So that is all part of life. So I have a fully equipped lab. What we have as of now is other laboratories in Jipmer are also basically research labs. Equipment is available. What we lack is, as Dr. Weber also mentioned, we lack, one is manpower and other is consumables to run on a longer period. So if those are available, probably we can start giving patient services by providing diagnostics for at least starting with some of the diseases, and then later on we can extend it to many others. There are a lot of administrative problems in that, many steps, but once we start putting our foot on the first step of the ladder, maybe we can scale it over time. Jipmer has been in the second group of institutes where centers of excellence are going to be granted. Jipmer was also inspected for the same. There were some plus points that were noted by the inspection team that had come, and there were some things which were lacking, so they have given some advice and comes through. We will be able to get a lot of help. So the reason I worked for about 10 years in government of Puducherry and then shifted to Jipmer was not that I was not happy there, I was very happy, but I wanted to be able to do something more so that I can get into research and then be able to generate. We need to generate data. We need to tell how many patients are there? Because this rare thing, as earlier it was said, it's a connotation that it is rare. They are not rare. So how do we bring down the prices of drugs? How do we bring down the prices of diagnostic tests? There is only one way: generate demand. Generating demand is the only way to promote any particular thing, get the government to make policies. So how will the demand come? Demand will come when there is awareness, when people know that there are places they can go and get diagnosed, they can get help. It is not always the final duty of the medical profession to cure a disease. It's also our duty to relieve anxiety, to make the family or patient know what they are dealing with, to give them succor, to give many types of treatment or therapy, not necessarily therapeutics, not necessarily drugs, rehabilitation, counseling. Counseling is a very, very important aspect, especially in genetic diseases. So there are so many aspects which need to be taken care of besides actually giving the drug and trying to cure the disease. So all these things are very important. We have a lot of things available now. I would say that the framework is there. We need to build upon it. And there was a time some 15, 20 years ago when talking about anything that is in the private sector was a big no-no for anybody who was working for the government. But now there is a big change there. Now we are talking about CSR and we are talking about PPP, which is a very welcome step, because it would never have been possible to bring up treatments and diagnostics for children with genetic disorders unless we shoulder the responsibility together. So I would say that we need forums like this to increase awareness, to bring people together, all the stakeholders, to be able to do something as far as possible, build up on what is available. Regarding diagnostics, there was a point made that we need to have molecular diagnostics. I am a very big advocate for that particular point, because over the time I had malaria, and it's not something that in India we really have to say, this is very rare, so we don't have money for it. Of course, there are multiple diseases which may need different types of drugs. Then every other disease also, diabetes needs different types of drugs, hypertension needs different types of. So how are genetic disorders different? They are no different. But what we need to do is generate numbers. So a lot of research has been going on, and now we know that the numbers are not very small. But I'm sure that we are still missing out the major chunk, because the 40% or 50% who are there in the rural area are not being diagnosed. So we don't have those numbers. What we now have is people coming to us. We are not going into the population, which is something called as screening. Once we start screening has been done for particular diseases like thalassemia, for hemophilia in some places. Thalassemia all over India, it's been a very big movement. So now we know what are the carrier status and other things, retinitis pigmentosa. So we need to generate our own data. We cannot depend upon what comes from the Western studies. One, their population is very less. So because their numbers are very less, they call it rare. So this data is coming in now. Now we can quote studies from India and say, this much is the number. But still what we have is not screening. Once we do screening, we will find that the numbers are extensive. We have a ICMR registry for rare diseases. I am a part of it. So there they are collecting data on those diseases which have been molecularly confirmed. So obviously, since not everybody can get a molecular diagnosis, we'll be leaking out a vast number of patients. So a pattern of collecting data and providing services. So it works both ways. It comes from the numbers, the data, how many, who has rural areas, urban slums. So all this data, once we get, it will come from the periphery, and then the services can be sent to these peripheral places. That is what is the need of the hour. But before that, we really need to bring in awareness, both for physicians and for public, make everything accessible. For molecular tests, when I started, the cost was something around 55,000 for each test, and I never used to advise it to my patients. Why? Because I knew that the patient who comes to a government hospital would have gone to a corporate hospital if they had money. So even if they say, yes, I will get the test done for my child, because that child is a very precious child to them, they will sell their land, they will pull other children out of the school, which is like killing a family for doing a diagnostic test. My conscience would never permit it. But now the same tests are available in 10,000, and over the time, the capacity of the people to pay has gone up, and now there are many patients who are able to afford. So I'm sure that in future, whatever ERT and other treatments are coming up, as the demand goes up, we need to generate demand. Demand will not come automatically. We have to do it. We have to generate demand from the public. So once the demand goes up, automatically the prices come down. More the drug needs to be manufactured, more the revenue comes in, obviously the prices will come down.
Yeah.
Yes.
Thanks a lot, Doctor. I'll come back to you. I would like to get a perspective of the other panelists as well. In context of Dr. Monica, you have been a medical doctor, then you have worked in international organizations from WHO to all the other UNICEF and other places, and you have worked in the rural pockets of India as a social worker as well. Now, listening to this, all this point of view, and you are now in the other side of the corporate angle. What is that is a holistic view in terms of molecular testing where the cost is high, how it has to be reached? Your views on that?
Thank you, and thank you, ma'am, for raising this important issue of awareness in molecular testing. Maybe I'll just take one step back and looking at the paradigm of all the rare diseases, right? Where does it all start? It starts from the birth. And most of the time, these are inherited diseases, maybe at a different level of manifestation. Some manifest very early in childhood, some manifest later in childhood. So if I have to see it from a perspective of public health, what is needed for the bigger part of the country is really at the core is the diagnosis. The sooner you diagnose it, better you are equipped to manage the condition of a patient. And which tells me that even before birth, you could actually diagnose it. And that is why we do antenatal screening as well. And knowing now that rare diseases are going to be a big burden in the future to come, why are we not thinking of making prenatal screening a mandate in India? And when I say prenatal screening, knowing how marriages happen in India, a lot of consanguineous marriages also, which also leads to a lot of these chromosomal abnormalities. Maybe the time is, how we say, a stitch in time saves 9, right? So if you could actually make prenatal screening a mandate for any couple who's thinking of marriage to go through this testing, and to ma'am's point, which was about generating the demand. The demand will only be generated in the sense when people are more aware that, and as now women are also becoming more career oriented, and there are late marriages happening, the chances of late pregnancy leading to more chromosomal abnormalities, incidences, it makes it more pertinent that if we could look at prenatal testing as one way of preventing, these rare diseases coming up. And then after prenatal testing, I mean, over at least my score of time spent in healthcare, I still feel antenatal screening is not a norm. I mean, forget how many women are actually going for their pregnancy checkups in the country. And if thalassemia has become a universal screening, it's also because it has become part of the antenatal screening program by the government under, prevention for maternal mortality. So can we not make antenatal screening a part? And then the third step, newborn screening, right? When a child is born, that time also, there's a lot of parameters for which children, newborns are tested. Why not make this also a part of it? And of course, then comes the point if there's a newborn baby, an infant, or a young child who's showing some symptoms of rare diseases, get them tested. So if you look at the entire paradigm, the cost that government will save in terms of, treating a patient who develops this disease and then getting the right treatment for the patient compared to the cost that government might spend in doing this prenatal, antenatal, and neonatal screening is going to be very less. So that should become a norm. This is more from a more comprehensive view of how you could actually prevent those unborn children, to not have those rare diseases. But if, unfortunately, a child is born with the rare diseases, I completely understand and echo with ma'am as well, that sooner you diagnose, and this cannot happen. And most of the time what I have seen in my own experience, why other countries are doing better than us is that even if, first of all, because their healthcare systems are publicly funded, because they are publicly funded, they don't have to worry that who's going to pay. It's already being taken care of. But of course, it also depends on the socio-economic status of that country, right? Has health been a focus for India? Incrementally, yes. But if you look at the healthcare budget, which is spent, the budget GDP spent on healthcare, 1983, we had an aspiration under the National Health Policy that we should spend 2.5% GDP on healthcare. Fast forward 2023, budget just came. We're still not there, 2.5% GDP. Of course, incrementally, we have done better. But with that population size and with that aspiration, and now with a bigger population size, and still not meeting that past aspiration, how would we expect that government would be able to solve for all and leaving no one behind actually? So I think one of the learnings that I bring back is like making a case for, more investment in healthcare from government. Only when you have more investment, you could actually think of tuberculosis, malaria, then ma'am said cancer. Cancer is still a challenge. I mean, along with me, I'm sure many biopharma companies sitting around would tell you that even still people are dying out of pocket, out of poverty, just because they're spending a lot of money on cancer treatment. And fast forward, forget cancer, rare diseases, I mean, they're still not under the radar yet. The National Rare Disease Policy that has come up, it only talks about one-time grant of 50 lakhs per patient. These are treatments which a patient probably would require all over his life, right? And have we provided enough budget for that? That's my first thing. And secondly, like I mentioned, testing, antenatal, prenatal, neonatal screening, early screening to detect for these life-threatening diseases. Because the sort of quality of life a patient has is almost despicable. And most of the time, caregivers are under the pressure. As much as they want to raise the child, they don't have the means to really do that. And then, of course, comes the cost of the actual treatment. And with the cost of the actual treatment, I mean, as much as private sector, we can look at many financial assistance models, whether it is about, let's say, blended financing, which is public-private partnership. It could be about interest-free loans for patients, right? It could be about social impact bonds. It could be about outcome-based treatments. It could be about crowdfunding as well. But all this will only happen when there is a commitment from both sides, which is public and private, that we can work together on a common solution and make sure that treatment is, provided. I'll just quote one more thing, and this is coming from hemophilia now. We were looking at the disease burden of hemophilia across the country, and we looked at the hemophilia burden of many other lower middle income countries. And to my surprise, if you look at the number of diagnosed patients of hemophilia, which is almost around 120,000 maybe for India, it's still 20% of the actual burden, because the diagnostic, and ma'am is sitting here. Exactly, but look at and they have been diagnosed because the penetration of diagnosis in India is still 13 to 14%, which means the actual burden of disease is going to be much, much higher. And think of rare diseases, other rare diseases then, which have a little, lower prevalence than hemophilia. We're not even there yet. So how many more, deaths are actually preventable if only you could diagnose in time? So like I said, my takeaways would be, a more commitment from the government, more commitment in terms of public-private partnership. Of course, we are here to support in whichever capacity we could do that. And early diagnosis, even before, a baby is born, should become a norm to ensure we can look at these challenges, not just at tertiary level, so that we don't have to wait for a patient to reach JIPMER or All India. This could actually be done at a district level hospital if you enable, right diagnosis in place, because all the doctors who are sitting in this gathering also, if you have the diagnostics machines in place, these testings in place, it's very easy to pick those patients very early. And this is how we have to think if we really, want to ensure that no one is left behind and we are able to diagnose all. Yeah, thank you.
Here we have...
Thanks a lot for the input.
Hemophilia incidence we have worked out is 1 in 8,000 to 10,000 population.
Right.
So you can imagine how many lakhs of patients.
Still undiagnosed.
Severe patients, still awareness is not good.
Got it. Now we have Dr. Srinivasan, who is the president of IMA Puducherry chapter. And doctor, we have been speaking on clinical points much way, but you being part of the forum, then administrative roles, what is that like a forum like IMA, a chapter like IMA, or for example, we had a ISTD from HR perspective, NIPM from other perspectives. From the IMA point of view, what is that bridge or what is the connect we can bring in? Your views on that?
Yeah, good afternoon. Thank you, Mr. Sridhar and Preeti Rajagopal for connecting me to this Health Connect today. I'm basically an anesthetist and been chosen in the wrong panel, I think. But anyway, as an IMA secretary and being the administrator, that is medical superintendent of the ESC hospital, one part is, let me talk about my own personal experience with the hemophilic patients, right? So one of my pharmacists actually is there in ESC hospital. He was working there for last 1 year before he took retirement. And like once in a month, he used to apply leave, right? Whenever I ask him, what is this, you keep on applying, then only I came to know that he's a hemophilic patient. So whenever he develops knee joint pains, he tells me, over the phone he calls, and then he says, right, I'm bleeding into my joint, knee joint. So I would like to avail 2-3 days leave, sir. I have to go to Virupuram Medical College and to take FIBA. Actually, FIBA, I just came to know today only, right, that only 4 patients are there here at Puducherry, FIBA. Yeah. Yeah, that is anti-inhibitor coagulation complex. That's what he said. 4 patients are there. So a lot of things I have come to know after getting connected to this Health Connect, right? So he was just telling me it costs around about 35,000 rupees. He has to take around about 3 to 4 vials. Comes around 1 to 1.25 lakhs. So just imagine how a common person can afford for this treatment. Next thing is, he was talking about factor 7 also, which I didn't know. Right, factor 7 also patients there, hemophilia patients there near in Tirupur, Coimbatore. So, what's the significant thing is ESI hospital is funding for this factor 7. I just came to know, and really I was so happy, right, being a medical superintendent of ESI hospital. I have to take up some kind of initiative because Madam also came to me actually. I remember, right, the first week when I took over charge of ESA Hospital, Nalini Madam came and she was asking for an help for one of the patients, right? What did I say, Madam? Immediately I said, yes, I will do it. So this is my attitude, okay? So we need like empathy, right? We have to be human, right? So whether it is a rare disease or a common disease. As a vice president of Rotary Club, right, and the medical chair of Rotary Club, what we do is actually, right, every Sunday, right, Annadanala, we used to do it for wherever. I can't say orphan, right, I don't use that word orphan at all, right, destitute. So old age home, we go like every Sunday, right, I get connected with a lot of companies, because every month, 1,000 to 1 lakh for the food alone, right, conducting CMEs. Because our Puducherry, we don't have a separate hall to conduct the CME programs. We are forced to conduct in the hotels. Why I am saying is, this through the Rotary Club, right, whenever a project comes, right, to me, so we go to the periphery actually, we go to the rural area, then someone will be asking me, right, this project cost around about 1 lakh. So I just put it across in our meeting, right, whenever we have once in 2 weeks meeting, actually review meeting in our Rotary Club, right. So this project cost around about 1 lakh. When I say, immediately one by one will start, right, 10 people. So 10,000 each will contribute for that project. So this is how the Rotary Club, as a vice president and medical chair. And apart from that, we are doing like cancer screening projects also through Rotary Club. We have our own Rotary bus actually, including the mammogram also. So that is stationed at Karaikal. So we do a lot of projects through Rotary. So when I came, when the Sridhar as well as Preeti met me, I was asking the same question. How come you got interested to this when doctors are not interested, like when companies are not interested? And one amazing person I could see, right, because Nalini Madam, Madam, you are an amazing person, right? All these years I've been seeing you are a dedicated person. I have had blessings actually from Mother Teresa. When I was 3 days along with her, I could serve here. When she was with the pacemaker, I was in the cardiology department. So same thing, like, so that kind of attitude, Nalini Madam, really Madam, you are great and been recognized now, and through our IMA also we are going to conduct one function for her exclusively. Thank you very much, Madam, for serving this society. Today, when I was looking at that mother of hemophilic patient, Jai Lakshmi, I think, see, yo, Pavo, Cho, These kind of things only we say, right, and we forget the very next day. So we have to look into those, right, people, right, how much suffering, all these, right, from third month onwards till date, how much suffering she is undergoing and turmoil. And we people are all disgusted, lot, little problems and all, we are disgusted, right? What is this problem has come to us? So it's not so, many people are suffering. But one thing is, as a like IMA secretary, like today after coming to know all these things since this morning I'm saying, right, we have to create awareness among our doctors first thing. So for that we have to conduct CME programs, the rarest diseases, and in fact 3,000 doctors are here. And we doctors are supposed to contribute, we should not blame the government alone. Our doctors also has to come, because recent through the WhatsApp I saw actually, Ambani was saying like, என்ன செலவு பண்ணலாம் அப்படின்ற மாதிரி சொல்கிறேன். So a common man is thinking, செலவுக்கு என்ன பண்ணலாம் அப்படின்னு. So we have to identify those people in the community, right? We should not, we have to take all these things to those people, because a lot of people there, even in Puducherry I'm saying, in my own Rotary Club, lot of people are there who can afford beyond that level they are there. They can give any amount of money. Only thing they should get convinced that this patient or that individual deserve. That's only one thing. So from that point of view, we have to identify such kind of people for this rare disease to get benefit, especially hemophilia. I would like to get associated with Madam also, because definitely, Madam, I will get associated with hemophilia. And I've just come to know JIPMER is giving factor 8 concentrate. I mean, they're we.
For the patient,
Yeah, that is what.
We don't give it for home therapy.
Home therapy. Oh, it's in the hospital, but JIPMER is doing a lot of work on hemophilia, especially factor 8 concentrate. And but even our GH also, sir, GH is giving factor 8, as well as Tamil Nadu, they're giving Gumadipundi Medical College. Then Rajiv Gandhi, they're saying. So, insurance scheme.
Yes, I would like to.
For that, what we have to do, Madam, you tell us.
I endorse Madam's point on this. This is something extremely important that Madam has brought up, that we can have insurance scheme through which many things can be done.
No, Madam, tell us actually what we are supposed to do from the insurance point of view for our Puducherry patients. We have 350 hemophilic patients, I believe. Is it correct, Madam? Yeah, and 4 FIBA patients, Puducherry. So, Sridhar, I can take on behalf of IMA and Puducherry, as well as being the chairman of Critical Care Society and the vice president for Rotary Club. And even in the government, I am the state nodal officer for COVID, oxygen, okay. So you just tell us, you just guide me, right, what I am, both of you, right? You just, it's my role actually, right? At least some person, right, I have to get associated with this Health Connect, especially for this rare case. And for hemophilia, society also, I would like to get involved. This is what I can say.
Yeah, thanks for this is just a beginning of the initiative, and we have been deliberating a lot of topics from the morning. And we have been deliberating a lot of points from the morning, and we'll certainly network how to go about and connect. And I want to request Mr. Suresh Venkatamani to come. He was part of the panel, but he had gone for a meeting with...
I would just like to make a point. I would like to respond to Madam. I mean, I can't go without responding to that. She brought up some very, very important points, not the most important point, which is prevention. Prevention is extremely important, definitely for so many other diseases as well as for genetic disorders. So the point that she brought up, neonatal screening or prenatal screening, but I would like to make one extremely important point here. Prenatal screening is already being done by multiple ultrasounds. 3 are advocated for every pregnant mother. So that prenatal screening is already going on by the government in all government hospitals. And of course, anybody who can afford to go to the private sector, that's fine. It is offered to everyone. It is available at quite a peripheral level. But I would not suggest molecular diagnosis, madam, for prenatal screening, because molecular diagnosis is not a very straight thing. It has many nuances. It has many complicated outcomes sometimes, and it has happened very frequently, especially in our population where consanguinity is very high. Many times you turn out to have abnormalities which have never been reported ever anywhere in the world, and we are not very sure whether they are actually responsible for the patient's disease or not, and it has multiple connotations, and we have patients coming with 2, 3, 4 diseases, genetic diseases in a single person. So molecular diagnosis is definitely neither for prenatal diagnosis nor for routine neonatal diagnosis. It will create a lot of problem.
It's even...
Yes, even neonatal diagnosis, what Madam mentioned, is definitely an in thing, but neonatal diagnosis is always done only for those particular conditions which are treatable. And there is a list of those. Of course, the list is going up in numbers, and definitely it's our future for India also. But I would still say that we cannot put the onus on the government to get every single neonate screened. So we have to find other ways, for which we have gathered today to find ways. But molecular screening is definitely not the answer.
Yeah, we are exploring a lot of possibilities, and in the sense we have other panelists who have come in, like Mr. Raju Pillai is there from Maratech. Before that, as a closing remark, it is one of the things which you do in Karkinos. It's on screening, and we would like you to give closing remarks on what is your idea. You have been collaborating with IIT Guwahati, IIT Madras, then with various states. So just, we have been deliberating on what is the best way to go. You heard Dr. Gulati speaking, and Dr. Monica and Dr. Srinivasan. What is that Karkinos can bring into this connect?
Okay, good afternoon, and apologies. I had to go out to meet somebody as per the directions of the governor, so I couldn't make it. I mean, our own view on molecular and precision is, world has evolved. I mean, world has completely evolved. And I was in San Francisco about 6 months back on a precision diagnostics conference. And, you know, when you look at precision diagnostics, and in fact, we had a conference, a global conference in Mumbai 2 weeks back, which was chaired by Dr. Shavanti Lemay. And we had Sanjay Dutt coming and speaking about his journey of how precision diagnostics and molecular helped in the early detection of cancer. So because we focus specifically on oncology, so from that standpoint, I can clearly say that precision medicine and molecular biology are these are the way forward. Now, what are we doing? What is Karkinos doing is, one, by virtue of the scale that we operate. Just to give an example, we started in the peak of pandemic. Today we have more than 3.5 lakh people who have come to my digital platform. And we are doing massive programs in collaboration with multiple corporates, government and other agencies. So what we foresee is a few things which is very core to us. One is, how do we offer affordable excellence? When I say how do we offer affordable excellence, rich or poor, right? Cancer is cancer. Life is life, right? So our intent is it possible for us to bring down the cost of molecular testing today? Some of the points which doctor said is very valid, right? One is today, no offense to the existing clinical ecosystem, we aren't trained well enough to actually adapt to molecular biology. Two is the cost at which it is offered today is prohibitively expensive. Only the upper middle class or the super rich can afford it. So we are doing multiple stuff. We are doing a lot of CMEs with existing clinical community and doctors. Dr. Shankara Narayanan, Dr. Shavanti Lamai, Dr. Ram Das, Dr. Moni Kuriakos. These are doctors who have given their full time to us. And Dr. Shankara Narayanan, we don't need to speak about him. He is the god of cervical cancer, right? So when you have influencers of that repute, and they are going and talking to gynecologists about the need for a migration or a paradigm shift. So what we foresee is, Karkinos is not an organization, we are on a mission. We are a bunch of people who have left corporate life, and today we are committing towards this. Now, what I foresee fast forward 5 years is one, the quality of knowledge ecosystem that we want to build about the whole molecular ecosystem. That's why we are doing with IIT Guwahati, IIT Chennai, IIT Bombay. Why is it that Mayo Clinic invested on us? Probably the only startup which has got both Reliance and Tata's on the same cap table, right? All of this goes to prove that our fundamental hypothesis of personalized care and reducing the cost, making it affordable. Uberization of, I would put it this way, given being a technologist, I would say what we are trying to do is Uberization of care. And I'm pretty confident that we will achieve, and all of us will probably gain from this. And we are extremely proud to have Roche being a very significant partner in this journey. Thank you.
Thanks a lot. With this, we'll close because other panelists are waiting for the next thing. If we can go for a quick tea break and come back, we can start by 4. At least by 4:30, we can start our next panel, if it's fine.
We are sitting here this morning, and a lot of people have been on discussion. Most of them all elite ones, greater people with greater knowledge. There are other people on the other side from this dais. So on behalf of the other doctors, I'm Dr. Kaveri, who has served 33 years in the government, and I'm also an executive in the IMA as well as a leader of the women doctor team. What I want to say is, we are talking on rarer diseases, how to take care of these rarer diseases, children or early adulthood. They reach up to early adulthood. And I know pharmacist Balaji, who has got a son who's a hemophiliac, and his son is a doctor today. So they live up to marriageable age, or they reproduce, and their progeny is also doctor today. So we want to save that community of affected with rarer diseases that you're talking, isn't it? That is what is happening. And how philanthropists like all these greater companies, private partnership can go in hand with the public sector. As simple as that is the wording today, Health Connect. If that is so, and if the wording partnership and sponsorship, what it means is what is going to be the sum total by this 4 p.m. that we are going to end. Digressing will not lead anywhere. Too much of knowledge is not going to save the common man. What is needed for those children is what we have to think of. What is common, and that has to be given priority. Even among the rarer diseases that you're talking of, I have been in pediatrics with Dr. Nalini Madam 33 years ago. I started with pediatrics, and the hemophilia then was there. We used to give blood transfusion, that is all that was going on then. Thereafter, the society, and today it has come up to drugs and molecular diagnosis and other blah, blah. Well, with that knowledge, I want to say, if we can save what are the common rarer diseases that you can concentrate and build upon in saving that. It will boil down to hemophilia, diabetes, early diabetes. A single man from Coimbatore like Dr. Chandrasekhar having an association called Idayam spoke 2 months back in the same stage where he's doing a lot for type 1 diabetes who require insulin, and that affordability, how he is giving. He reaches those children who require insulin right from giving a refrigerator free for them. And those children who require that insulin are living not, who used to die like fleas by 7 years or 8 years and 10 years, are now living up to college age. And up to college age, they are supported. And after that, they are given a livelihood to take care of their own supply of insulin. See, so it is not just a day's process that we are talking of. We have to first see how you can find out, then stabilize, and the maintenance should go on. So in that way, what is common, you concentrate on that. So you can take up, I feel, you can take up the people out here, concentrate on what is already there in this place, that is hemophilia. Madam is doing, her society can be helped, and there is a big institute like JIPMA where a full-fledged pediatric department with DM in various categories of pediatrics is going on. There they can be supported, and then we have the genetist or molecular madam who is doing a lot in it. She can build up on that, which can all be sponsored, whether it should be partnership or sponsorship, or both. If we see, I always feel partnership will never work out fully. Partnership always has, see, if it is partnership, one or the other will always have an upper hand or try to do greater one, become great. So
Doctor.
Partnership in business is not a very nice word, but in business, sponsorship, if you're going to do, being philanthropic people, you can always sponsor. All the companies can sponsor for all these already existing institutes like JIPMA, Hemophilia Club, and for Down syndrome. These are the three rare things which are happening more in our country. Then, see, you have muscular dystrophy, but how long do they live? We have no right to write off anybody.
Doctor.
There are children dying out of anemia, malnutrition, lack of vitamin A, going blind. When
Doctor,
there are so many on that, and there are less people on this.
Dr. we have
So
taken...
I think we should come to a conclusion where the source, this is all boiling down to where the resource can be utilized for a better cause. So I feel sponsorship should be the word here rather than partnership. And as a government person, and as I know, like Dr. Murali, it never works out. The government will never permit. But what the government can do, as an officer, I would like them to give permission for all the doctors sitting here for giving a reference to utilize ICH. Sir said he is doing it free of cost, and it is close by. We should be given permission.
Excuse us, doctor, because we are...
Such kind of permissions and protocols should be drawn, is my feeling.
Thanks a lot, doctor. Thanks a lot for your point. We can break for 10 minutes and then we'll come back for the next panel. Sure. Thank you. We have to, as a formality, we'll do the memento to be given. Suresh, you can give memento to Dr. Srinivas and Dr. Monica to Dr. Reena Gulati. Shall we bring it? She's from Delhi.
Yeah.
Thank you.
My younger sister is Yes, 10 years I spent there.
She was working on
We can feel that from our way of
the rare diseases component ultimately. So I'll be moderating a session. My name is Sudhakar. I run a company called TRST Score or Trust Score. So I welcome the panelists. Thank you all for joining us. Really appreciate you taking the time off during your busy days to be with us. Thank you very much, sir. So let's try and see, what are we going to do about this entire rare disease? I mean, there is a lot of people who have spoken before us about rare diseases, and there was a lot of heated discussions on how we could try and prevent or rather catch it early. There was a lot of phrases used over there. But ultimately, all this is possible only through funding. Ultimately, the bottom line is you need the money to make it happen. So how are we going to bring that focus of the CSR funding that is available in the market? How are we going to channelize it, at least some portion of it, towards this particular thing, and how are we going to make it happen? I'm thinking this would be an ideal question for Mr. Mannadhanan. It'll be great if you can take this question, sir.
Good evening to all of you. This is the last session. Naturally, you all should have been exhausted by this time, and some of the participants have already left. But still, it's our duty to do some justice for whatever efforts this Health Connect has taken. Mr. Sridhar and Preeti has been chasing us. I was inducted in the last minute. Fine. CSR fund, how best we can utilize it, that is the topic. I am an industrialist. The name of my industry is Manatech. Probably Pondicherrians must be knowing. I am the chairman of the Manatech group of companies. The CSR fund is meant for so many social activities for the people who are surrounding the place in which the industry is or the business is situated. That is the idea. It's an excellent idea by the government. 2% of the profit before tax is supposed to be spent on CSR activities. In Pondicherry, according to my rough calculations, around 100 crore rupee is available every year, and it must be increasing. The whole problem in Pondicherry is we do not know how to send the CSR funds, because the CSR regulations prescribe certain norms. நீங்கள் இதுக்கு தான் செலவு பண்ணலாம், இதுக்கு செலவு பண்ணக்கூடாது. There the IT department has got a lot of regulations. Therefore, it is very difficult for we industries to spend some money and tomorrow it will be disallowed by the IT department. Hey, whatever money you spend, it is not CSR activity. This has happened many times. Fearing such situation, many companies have started contributing the money to Prime Minister's Relief Fund, which nobody can question. But believe me, CSR fund should be spent in the area, in the nearby villages where your industry is situated. That is the basic logic behind it. Unfortunately, because of the IT department's non-clarity, people do it. But we have to take some experience of other places like Coimbatore. In Coimbatore, I find a lot of, there are a lot of organizations, social organizations comprising of doctors for treating this kind of rare diseases, and also like burn victims. See, I am contributing to the burn victims every year because I do not have an organization like this in Pondicherry. Therefore, the Health Connect must try to create avenues which are approved by the IT department to attract all the 100 crores only to Puducherry. Let me be selfish on it, nothing wrong in it, because there are a lot of villages, lot of patients who are not able to get medical benefits, and they cannot go to corporate hospitals. They go to the government hospitals where they cannot get the full-fledged treatment, and naturally this kind of organizations must come and grow in Pondicherry. That is very important. The Health Connect Pondicherry, if they can institute, probably we can take the model of Coimbatore, nothing wrong in it. Coimbatore is doing very well. Those doctors, I saw one doctor was so philanthropic in his speech, we can rope in all of them and try to attract the CSR funds. Okay. CSR fund is not only for health, it is for so many other things, pollution and education and even environment. So many other things people can spend, but I will definitely say health is the foremost of all these expenditures. That is one thing. Number two, I found in the recent budget, 83,000 crores have been allotted for health care. It's not to criticize anybody. About 4 or 5 years back, skill development, 50,000 crores was allotted. I was called as a speaker in Taj, Chennai, because I belong to industry and I am good at skill development. I went there and I gave a lecture. About 30-40 people like me gave lectures, and they gave me fabulous gifts and all. Beautiful. But the people who attended, they have nothing to do with skills. They are all professors in colleges. Skill development must be conducted where? In ITIs, right? Where the +2 diploma holders are more. See, what happens, the good vision of the government, unless the process is set end to end, the scheme fails. That is very important. We get lot of money now. GST revenue, every year you are seeing the newspapers, it is going on galloping because the GST net is very wide. It's good thing. Government gets revenue. They allocate money. But allocation of money alone is not important unless it is ensured that it reaches the final destination. That is very, very important. How we are going to get our share for that? How those money is going to be utilized? Probably Health Connect kind of organizations like Dr. Kaveri, I think your name, right? Right, doctor? Yeah, she was very rightly telling instead of partnership, it should be sponsorship. You have to tie up with the government at one end, private parties like us on the other end, so that the observations. I thank Health Connect for giving this up.
That was wonderful. In fact, the Puducherry government should, just like they have the PM public-private partnership into the whole storyline. And from a corporate standpoint, we need to be able to figure out, is there any way that this public-private partnership, like I was proposing for the government, for example, would something like this work? If at all, how? And would companies would they contribute to this whole storyline? Mr. Prashant, your views on that? And let's try and keep this question answers to about 2 to 3 minutes maximum. That will help us.
I'll make 3 quick points. Point number 1, the key differences between any developed country and any underdeveloped country are 3. Number 1 is health, number 2 is education, number 3 is infrastructure. Most underdeveloped countries latch on to infrastructure, which is very good, and most underdeveloped countries miss on health and education, which is where they continue to be underdeveloped for 70, 80 years and more. And the countries which take care of all the 3 pillars are the ones who move from being underdeveloped to developed. Now, point is that whatever is happening, so as I heard somebody saying that government is willing to permit, that's my second point. Governments have to move from permitting to enabling. This whole thing of authority that I will permit has to go away, and governments have to become enablers. Point number 3 is that this whole discussion, partnership, sponsorship, etc. I think Sir has already made a point on getting an approval from IT department that these are approved initiatives for CSR, so I'm not going to get there. But I think there's a learning available to us from the way the Western universities have been run for several hundred years. It's certainly sustainable, where you have an endowment fund which is separate from the university and with a separate board, and the endowment fund is where all the contributions come, and the job of the endowment fund is not only to generate funds but also to invest them properly so that they get good yield, so that they're not spending the money that has come, but the interest or the dividend on the money. And for example, the Harvard University Endowment Fund also has the responsibility towards the donors of ensuring that the Harvard University is properly utilizing those funds. So raising the fund, investing them, and ensuring proper utilization, right? And that is an independent body which ensures proper utilization. So the money is not with Harvard University, it's with the endowment fund. So can we create a Health Connect Puducherry endowment fund, right? Or whatever that name could be, with a separate board, which takes all the donations, creates an endowment fund so that it is sustainable forever. If it has been sustainable for these universities for 200, 300, 400 years, it can certainly create something which is sustainable. The problem with the way we run our NGOs is that we take donations, we spend them. And then next year we're again there to get more donations. The problem with that approach is the year the businesses go down, there's a pandemic, there's a recession, there are no profits, and therefore there are no CSR funds. And therefore there are no donations, and then the NGOs start winding up. So if we have to make it sustainable, we have to create an endowment fund kind of model where the money gets invested and maybe part of the money gets used because our endowment funds will not be that big. Part of the money gets invested so that the year there's a downturn, you already have a pool, and if the corporates are not contributing, you're not winding up the support to people. So that kind of model, if we set up, that also gives a lot of confidence to donors. While people in Puducherry will certainly, corporates in Puducherry will certainly contribute, but the point is, how do we get Tata Trust to contribute? No, they need assurance that the money will be properly utilized. How do we get the ABG and the Mahindra, or the Sanofi or the Abbott or whoever else to contribute? They need an assurance that this will, apart from the income tax problem, assurance that this is being put to good use. And that's the purpose that the endowment fund or equivalent endowment fund I'm borrowing from these universities serves, and becomes a watchdog on all the organizations that are involved in providing the service and utilizing these funds. So those were my 3 small points. I am just learning about rare disease, so I don't have anything to talk about it. But yeah, how do we attract these corporate funds and how do we utilize them? I had some learning which I thought might be worth sharing.
Wonderful, sir. That's a very interesting suggestion, by the way. I request Mr. H. Raja if he's here. Okay, all right. So, great. So coming to the next level, right? Mr. Prashant has opened up a few new things ultimately. And associations like yours, basically ability, the ISTD association and the NPM association, for example, all of you wield a lot of power if you look at it over the corporates and their ability to do a lot of things, because you're a collective decision-making body practically. And as a collective decision-making body, you can bring a lot of attention to certain issues that are being brought up here in the Health Connect as an example. And do you think that associations should even play a role, if at all any? Do you think that it would be viable to make a proposition through the associations for that matter? And how do you think that companies can contribute and be a willing participant, like Mr. Prashant said? How can you bring those kind of endowments? Is there a way that all of this can be accommodated through the associations and stuff like that? That will be your view, sir.
Yeah, thanks, Mr. Sudhakar, for the question. And I belong to HR domain, and also incidentally, I chair ISTD Chennai chapter. And my first introduction to this rare disease happened some 15 years ago when I was working for a company in Hyderabad. I was managing one of the plants in Hyderabad, and an operator used to come to me oftentimes and used to plead for some regular help, permanent help for his kid. Then he explained something called thalassemia. I never heard about that, thalassemia. And way back 2007, 2008, okay, though the internet was available, but we couldn't get much of, I couldn't get much of information about this thalassemia. And there was some NGO that was extending support to the worker, and he tried his level best to muster funds, and what I understood was every week or every 10 days blood transfusion has to be completely done, and it was costing some 3,000 rupees in those days, 15 years ago. I have no idea what is that today. And I represented my leadership and so many people. The kind of response what I received from all the people I approached was that it cannot be cured, so why do you worry about that? They didn't say that much. They didn't say that, but the body language almost communicated to me that he's a crazy guy. I think you are representing a case which doesn't have which cannot be cured at all. So it was really a little very painful experience. Finally, we couldn't do anything. I had no idea. I left the organization, and incidentally, I joined a pharma company called Pfizer. And in Pfizer, I learned a lot about rare diseases. Of course, Pfizer has an independent division that gets into the business of evolving discovery drugs for rare diseases. And my learning in Pfizer was, it's not that easy to discover a drug for rare diseases, and it's so expensive. R&D sucks millions and millions of dollars, and when it is showcased for sale, obviously the rare disease drug would cost something beyond the ability of the common man. And after Sridhar explained me a couple of months ago that he's into this noble cause along with Ms. Preeti, and I started browsing a lot, and I understood that, oh God, there are about 7,000 plus rare diseases that about 35 crore population across the world are affected by this. And what I learned from my first encounter with the father of the thalassemia kid was that it's not, this rare disease doesn't affect the patient alone, it affects the entire family. And the parent couldn't take a promotion, he couldn't learn a new skill, the mother couldn't go for a job, the mother was completely tied up to the home, and it affects the entire, the ambience of the family. That's my lesson. And taking clue from Honorable Governor this morning, what I think is we, the HR Forum, can support in two ways. One is the prevention, education, educating the rural or the so-called not so enlightened mothers in this area, and help them to prevent it. Number two, curing, creating awareness and also curing. And let me tell you, the HR associations are very strong. HR managers associations are very strong. And I belong to ISTD, and my friend sitting just in front of me, Mr. Raja, and he's the national president for the oldest HR association called NAPM, Delhi, and he has got national connect.
I'd like you to come on stage, sir. Please.
Please come. And one more HR association called the National HRD Network, that's also very powerful. And S.V. Nathan, who's the executive director, one of the directors in Deloitte, he is the national level chairman for NHRDN. And MMA, CII, we are all connected. And we HR forums are strongly as well as emotionally connected with our vendors. A canteen contractor, a transport, a bus vendor, a transportation supplier, and a recruiter, and a background verification agency, and a psychometric service providing agency. And it's not that business transaction alone. We are emotionally connected with this ecosystem. I would say it's HR ecosystem, people management ecosystem. And more than half of our vendors are from very low level, okay? And common man, I would say, common man. And I wish that if they are educated about these rare diseases, they can easily carry it to their neighborhood, because they are common man. They would have seen many people suffering with rare diseases, number one. And another set of vendors, okay, they are rich and they can fund or they can donate or they can sponsor the programs. This is two things. Another thing is the trade unions. HR forums are closely connected with trade unions, emotionally connected with trade unions, and we can best use of the trade unionists also in creating awareness. And the Pondi alone has about 3,000 HR managers, I would say. 3,000 HR managers, 3,000 plus. I am quoting a few small number. And at any point in time, at a call, a minimum 300 HR managers can be present. Cannot be all the 3,000, and 300 can be present. And I wish that if Sridhar is okay, I can take the lead in having one more conference of all the HR managers somewhere in Puducherry. and give them a kind of detailed awareness of what this problem is, how can we help.
Thank you, sir.
Right. So this is how I think that we HR forums can help this concern in mitigating to an extent. That's
Great,
the
sir.
take.
Thank you, sir. Thank you. Mr. Raja, thank you for joining us. So we were thinking about, employees become, a core component in the problems, because ultimately every HR is worried about their employees ultimately, and CSR funds, directly or indirectly, they wanted to benefit the ecosystem that they are coming from. So let's say he's running a company, he wants first to take care of his employees, then his local city, then expand and expand and expand, is how he basically looks at CSR funds practically. Now, do you think that as a HR forum that you basically run and so on and so forth, how do you think that we can bring this focus onto, first of all, bringing an ecosystem around first the employee system, like you said, and then expand it and expand it and expand it. Do you think that your forum can play a role in that particular way, sir?
Good evening. காலை வணக்கத்தை ஆரம்பித்து இப்போ மாலை வணக்கத்துக்கு வந்துட்டோம். சார் சொன்னார் இடைச்சொருகள் கடைச்சொருகள்னு. ஆக்சுவலாக நான் தான் கடைசி ஸ்பீக்கர். ரியலி இது கடைச்சொருகள் நான் தான். Actually, I was there in the first, then, moved to last. So, we have an advantage. And I've been pathina, whatever, we prepared ourselves, it is all spoken, But as a HR person, so we always proud and see how you can, help to the community. First, let me congratulate and compliment Professor Sridhar, Preeti, and others for putting this conference. See, I have let me tell me about myself first. I am Raja, I am HR profession, turned even entrepreneur. And I am not a national president. I am the National General Secretary of NIPM, which is one of the oldest HR forum in India. Okay, see, so today we all know very well that we are all electronically connected, emotionally disconnected. Okay, so when we talk about rare disease, the common disease itself is not having an awareness, which we are all we all would have come across at least couple of instances in our life. Even I have come across few major losses in the last recent couple of months. See, the first and the foremost important thing is this creating the awareness. How we are going to create this awareness, as my friend Mr. Vijay said, connecting with the people. So we always say that drive from the top to the bottom. When our friend the CEO, when he says that, so who is the topmost person is a person who is working on a contract employee, who is, put it in other word, highly unaware of, and the other side, where, he was not connected properly with the awareness of what is not only the rare disease, even on the common diseases. As a HR forums, we can, always wanted to ensure, these people are, get educated. See, today, the health check is become the common. But how far some basic messages taken from that health check is unaware of it. Similarly, this kind of a rare disease, we wanted to ensure that we work with the HR managers and part of their induction program. We wanted to include these kind of an awareness program during the induction time, so that by forcefully, say during the induction, be it at any level in organization, there is an induction program where certain organization values and cultures, systems and procedures are explained to him or her. So this also we feel that it should be taken in the forefront, where these messages can be communicated. So I'll stop it here. Sudhakar, over to you.
Great. So thank you, sir. Thank you for that. So by the way, I have a couple of contributions too while I have this. So basically, I think insurance companies can give an add-on cover as a simplest thought process, right? So there is an add-on cover called rare disease cover. Today you have cancer cover and you have all these things. One of the contributions could be on the add-on cover, which could be given in the insurance health policy. In fact, if you ask me, if all of them could contribute 5 rupees extra in their policy, in fact, rare diseases can be covered for everybody because it is a rare disease anyway. So if you really think about it, if all the entire ecosystem can contribute 5 rupees extra to their premiums, they could actually cover the entire country for rare diseases, and any cost that might actually be incurred as a part of that could be done, and an additional add-on cover can also be given as a part of the health insurance cover as an example. And of course, the government health insurance policies also should be brought in to basically allow for such, because I know Tamil Nadu government, I don't know whether Puducherry government has it, but if, for example, they provide the health cover, which the Amma scheme or with the new the health insurance scheme given by the government, and in fact the central government is also working on the scheme which could be done. And again, another thing that always I was kind of unimpressed with is the fact that why cannot all corporates, for example, allow for their companies, or even government can say whoever wants to be a blood donor as an example. Why isn't there a common blood donor pool that is created? I have no idea, because everybody who wants to have blood, for example, they have to go through their friends asking me whether you have blood, whether you have blood. But what if there was a common pool, like a donor list practically, which could have actually helped people with rare diseases who need blood transfusion as an example on a continuous basis, for example. And it could be even enabled with your technology. They have created this Connect app, for example, which could also be done as a part of the entire ecosystem. So, sir wanted to add a couple of words. I just wanted
to. Employee welfare is not considered as CSR funds. Employee welfare cannot be considered for CSR expenditure. We all should understand that. CSR expenditure is only for out of employees. Right. Number 2, I request Mr. Sridhar to conduct a similar meeting calling all the industrialists in Puducherry so that you can communicate your ideas, request to them. And as a past chairman of CII and MMA, I will definitely help you out. One more point, the Chief Minister's Relief Fund is not applicable. If you donate for that, it is not applicable for CSR.
Great. Good to know, sir. Even I didn't know this information, by the way. But thank you all. I really appreciate the entire panel for giving their views on this whole storyline. And that's all the time that we have. And thank you very much for all of you to come over here and give us your time and to speak about it in this panel. Thank you very much. Have a great evening.
Thanks a lot, Sudhakar, for pitching in. And கடை சொல்லுன்னாங்க, பட் திருக்குறள் வந்து 2 வரி தான் இருக்கு. அந்த 2 வரியில மாதிரி எல்லாரும் பேனலிஸ்டும் you have spoken the key important things, which is the source of funds, as other doctor was mentioning finally. So திருக்குறள் வந்து 2 வரி தான், அதே மாதிரி தான் இந்த 20 minutes முடிஞ்சிருக்கு. But it's a great panel, and I request Mr. Anil of Sanofi to give memento to our distinguished panelists. And Mr. Raju Pillai made it at the last moment. We asked him, sir, you have to pitch in for absence of somebody, and he was very generous to come and be with us. And now, yes. Group photo. We will go for the limelight of this evening with valedictory function and honoring one of the important persons today. I request Raju Pillai sir to be in the stage. I request Dr. Nalini madam to come to the stage, and Dr. Ara sir and Dr. Murali. I request Ms. Preeti Rajagopal to come on the stage as well. Mr. Anil sir, please come on the stage. We have Dr. Monica also. You can also come on the stage. We have come for a valedictory program. One more chair. We didn't know that you were here. Mr. Suresh. Yeah, please, sir. I'm missing out on the audience. I didn't know that you were here. Sorry for that. Thanks to each one. I will start this valedictory with a thanks note. Thanks to each one of you who are here from morning to evening, and that too on a working day, that too the second day of the week. And this event, the speakers have come from out of Puducherry, except for a few and some other government officials. I thank whoever has taken efforts to travel out of Puducherry and come in. And also, we having the Deputy Director of Health Department of Puducherry for the whole day itself speaks volumes about the commitment and the partnership which they would like to dwell upon. And the key people of healthcare fraternity of Puducherry were here today. And we had expert panelists like Dr. Arasa, who has taken his whole day to be here. And each one of the speakers has made a big difference. And Tamil சொல்லிட்டு நான் கடை சொல் அப்புறம் திருக்குறள்லாம் பேசிட்டு இருந்தோம். What our objective of Health Connect is to take the essence of this conference. It is not just we conduct a conference and close it out. Whatever we have committed from the morning until we have videotaped, and we'll take a consensus note on this along with all your inputs. And as we told in the morning, we'll be working closely with the Health Department of Puducherry. And we'll pursue with all these partnerships. And I thank Raju Pillai sir for saying that we should conduct a session for the industrialists of Puducherry, which will be a very big support for us to start this. Because it is not only one person can handle this concern. And with this thank you note, and I don't want to take much time of each one of you, I would request from our Health Connect side, and Dr. Nalini Madam has been participating in our initiative, and from the distance angle she has given a lot of inputs, and she voluntarily came on for the pre-conference meeting and she was there for all the 4 hours, in spite of she at 80 years. That itself shows how much you are committed to the cause. I now requested our Deputy Director Murli, Dr. Arasar and Mr. Raju, everybody to honor with a Lifetime Achievement Award to Dr. Nalini. Let us have a big applause for her.
நீங்க நிறைய ஷால் கலெக்ட் பண்ணி ஆகணும்.
எனக்கு நிறைய honor கிடைச்சிருக்குது. This is the greatest honor. Definitely. So give this memento.
Please visit our center sometime. Yeah. நீங்க அந்த பக்கம் பாஸ் பண்ணும்போது தேர் தான் தரணும். நான் இல்லைன்னா கூட எங்கள் ஆஃபீஸ் மேனேஜர் எல்லாம் He's a great supporter of mine. He's a great supporter of me. First person who came to honor the
We would like to... Yes, ma'am, please. Mic irukanga.
Good evening, though it's very late. Thank you very much, Health Connect, for honoring me and also conducting such an excellent function. I never thought you would get so many doctors. I was wondering how you are going to get the doctors. You all individually have got all the doctors and also the corporate people. Thank you very much, because Puducherry is a small niche. So it's very difficult for me to, I myself know how difficult it is to collect funds in Puducherry. Though it is because of my personal, influence from my friends that I have collected funds for my society. Thank you very much for bringing so many corporates. This is the first time I've rubbed shoulder with so many corporates. Government people, of course, I know, but corporates I'm seeing for the first time. Thank you very much for all of you for coming to Puducherry. Thank you once again. Jai Hind. I feel this is the year of Nari Shakti, and as a woman to get an award, I feel very much honored. I thank the central government, especially the PM, but I also have many things to work. Now this gives me an impetus to work further, run further, though I am in the late stages, but I think I have got the impetus to run further and do much more. So I will be disturbing many people now, again and again. So you may consider it a nuisance now. Oh, this lady has become a nuisance now. So thank you very much once again. Thank you very much, authorities of Health Connect, who have been involved in this. Thank you one and all for staying for so long. Thank you. somebody.
Do the national anthem and then take
National anthem has been done, no? That's enough. What's
The request is coming for us to have a group photo. I request everyone to come to the stage. Ganesh, Sandeep, Sriram, please join us. Dr. Reena Gulati, all of you please join us. It's Health Connect is to connect everybody towards a noble cause. All the doctors, please join us. Yes, all of you please join us. Come. Karthik, please join us. You have been a big supporter for us. Please come.
It's a good idea.
Yes, it will come. Please come.